I hope that you all will enjoy in the next 3 days, along with the climate, the lectures also given by the experts. And I really thank all the sponsors also who have come readily and who have sponsored us also. And I welcome all the sponsors, I welcome all the delegates. And the first session will be by Dr. M. Chandrasekhar, will be started shortly.
Remove the paralyzed solution. Then we connect it to the machine. And before connecting the set of procedure normally we do, what the procedure we do called priming we do. And for that, the machine will give set of instruction that we follow. Initially we have to take the cartridges.
Dr. M. Chandrasekhar needs no introduction. He is Professor of Clinical Medicine in Madras Veterinary College, known to the entire length and breadth of the country. I request Dr. M. Chandrasekhar to take the stage.
Respected seniors, friends, and dear veterinarian, industrial partners. Today, they asked me to talk about dialysis technique in veterinary practice, though we have been doing the technique for a couple of years. Whatever the input, whatever message which we gathered, I would like to share it in this platform. The main objective of why we've taken up this work, So, we don't have, as of now, till date, we don't have any artificial kidney for our child or any human patients. So, all are important. In that context only, there are two IIT professors. One professor from Anna University, they approached me to carry on the work in dialysis. So what we did, we carried out a trial in animal model. We got approval from the Animal Welfare Board. Then the two IIT professors, they are preparing the artificial kidney. They are preparing from some polysulfone made fiber. And we have been doing there were a lot of issues in the beginning. Even the Wright brothers, when they invented flight, it didn't go smoothly. Initially, entire world, they criticized the scientist. Here also, there are a lot of lacunae we observed. We carried out the problem. Shortly, we standardized the protocol. The artificial kidney, first in the world, it will arise from Madras Veterinary College with the availability of the two IITs. One is Mumbai IIT, another one Gorakhpur to IITN. It will come in the market. Almost our standardization is over. It is giving a wonderful result. And what we did know, so we had a known quantity of blood urea nitrogen, creatinine in the dog blood. So imagine you all doing a blood transfusion, known quantity of blood urea nitrogen, creatinine, we added in the dog blood to mimic the similar modality of the dog uremic blood. Then the artificial kidney made by the two IITN, we carried out the trial. But our patients are very smaller. Maybe our patients start from 3 to 10 kg going up to 70 kilo. What we did know, for a 3 to 10 kg patient, we need a 0.3 meter square. We need a small size cartridges, artificial kidney. And moderate size, we need 0.6 meter square. Bigger dog, we can use 1 meter square, similar to that of human being. That is the basis we started the work. And I helped them to set up the dialysis unit in Ludhiana, Gadwasu. And I helped the Hyderabad Veterinary College to set up the dialysis unit. Recently, I have been to Bangalore also to help them to set up the dialysis unit. And through this work, I'm going to link the entire institute in the country. So, but our data can be generated. We can share it to the research parent institute. So, we'll submit to the Department of Science and Technology. That is the basis we started the YouTube's videos. So, I thought of playing images and videos. Everything available in the power of PowerPoint, we can share through Venkateshwaran sir, and other people will share it. We will put it in the group. And before going to the real presentations, see, nowadays we can give money, we can give food, we can give anything. But spending money for the education, nobody can do. So that is SAPAC is doing. Big hand to the organizer. So for this type of program. And so all the speakers are eminent speakers, and they are doing a pioneer work. So coming to this case, this is a continuous renal replacement therapy. It is a high-end modality. So what we do now, collar mic. Okay, maybe you can see from here. So this is actually the artificial kidney. This is actually a ready-made one. It's a high-end modality. So what it does now, it contains several thousand small fibers, like my small fibers are there. Through that only the blood goes. So the clearance are taking place. So the clearance are taking place with the diffusion, convection, and ultrafiltration. Diffusion, from higher molecular weight substances like blood urea, nitrogen, and creatinine, from the patient blood, it goes to the dialysate solution. So bottom of the machine, you can see there is a normal saline. We give a dialysate solution, replacement solution. This goes in opposite direction. Blood coming in a downward directions. Because the change in the directions, and then higher value of blood urea, nitrogen, and creatinine from the patient blood, it goes to the dialysate solution. So the dialysate solution containing bicarbonate and a certain electrolytes that are essential for the cell survival, like sodium chloride, calcium chloride, bicarbonate, and so on, that they will come to the patient blood. So the clearance are taking place like this. Sometimes this is called diffusion. Sometimes what they do, they also create pressure on the fibers through the blood. The machine, there are software modification. It creates the pressure. With the pressure also, the higher value of blood urea, nitrogen, creatinine goes to the dialysate solution. So the patient is not losing even 5 to 10 ml of fluid or the blood, the entire process. So all the exchanges are taking place in this artificial kidney. Once it purified, the purified blood sent back to the patients. This is the concept for intermittent hemodialysis. This is the concept for continuous renal replacement therapy. And several other indications also available in this. Suppose the patient consumed unknown poison. You may not be knowing the antidote for that. That would have caused multi-organ failure. For example, this topic related to the dialysis, imagine that causes renal failure. For example, you take the dog was bitten by a viper or a cobra, so you couldn't realize what type of toxins that causes the multi-organ failure, especially renal failure. Majority of poisonous snake problem, even if you try with antivenom, if you are not able to succeed, that will go for renal failure, multi-organ failure. The best modality, better subject the animal for dialysis because that will purify the blood. And with this case, if you don't know the toxin which causes the multi-organ failure, there is an artificial kidney available with activated charcoal. You all know that activated charcoal is an universal antidote for majority of the poisoning. So what you can do is, if you don't know that, what you can do it, you can mix the activated charcoal. You can do one technique called gastric lavage. Just introduced orally with the stomach tube, so that it get absorbed, the toxins that are available in the stomach get neutralized. You can save the patient. This is one method, gastric lavage. What about the toxins which are enter into the system? So what you need to do is, so with the activated charcoal, when the blood goes there is a technique called adsorbent. It will absorb the toxin, so blood get purified, it goes to the patient. This is one of the method, adsorption technique. First I told diffusion, another one I told convection, and the third is about adsorption. These three techniques only playing a major role. And before that, for sending the blood to this machine and artificial kidney, and what you need to do is, you have to good at putting a center line. And we all know that all of them, you are good at putting a jugular access very easily. But the only thing is patient which are thinner, patient which are obese, it becomes challenging. So what they studied, they carried out nearly 150 animal jugular catheterization. What they advised, and there are certain standardization they given. So what they do, if you don't sedate, it is very difficult. Maybe use butorphanol 0.2 mg per kg body weight to calm down the patients. Then you can shave the fur superficially on the jugular side. With the ultrasound guidance, just introduce the needle. That's one technique. Even manually also, jugular vein is superficial. Why? We are talking much about central line access. Rest of the blood vessel, you cannot take that much of blood. The scientists working all over the world, you cannot take from femoral vein or femoral artery. You cannot take from saphenous vein, saphenous artery. You cannot create arteriovenous fistula. Because in human patient, arteriovenous fistula, they create the fistula healing itself will take 45 days. Majority of our patients, delayed referral, with most of them coming to me from neighboring district, neighboring states, having elevated value of, creatinine in 15, blood urination 250 milligram per deciliter. That's the status. Normally, it used to come to me mainly on Friday time. So the message is, you must good at putting the central line access. So there are certain images we have. I'll tell you how to go about the central line access and all those things. I'll tell you one by one. Next slide. Suppose if you are trying, next slide. Next slide. So this is the basic function. Kidney is, sacrificing organ. It filters all the unwanted materials. It will also take essential nutrient for our body needs. And it also, secrete all the unwanted materials. So these are all the basic function, the kidney playing an important role. And your homeostasis of your body, kidney playing an important role. Previously, other organ failure, they talked more. Now, the kidney playing an important role, protecting all other organ. Next slide. So the basis is pre-renal, renal, post-renal causes. Pre-renal causes, and I will come to our case, majority of a hemoproteasome disease. Why we are getting a lot of renal failure? Every day, 300 cases we are getting in Madras Veterinary College. Out of that, maybe I will say 40 cases are renal failure. Why the 40 cases are renal failure? We get into a lot of work. We observed when I was a student, my work on Ehrlichia canis. Ehrlichia canis also causes renal failure. It damages the nephrons, tubules, and the glomerular basement membrane. And so once it damages, and in recovery it takes longer time. And so that's the scenario of 15 years before. Now we get a lot of Babesia zibzoni. Babesia zibzoni also, it's a multi-system affecting rickettsial disease. And once the major important organ affected is the kidney. That's the reason we get the majority of the renal failure. And the most important things, before going for any procedure related to the renal, you have to give a counseling to the owner. How many of you are having a counseling room in your practice? Just raise your hand. So you have to keep. When I was in Michigan State, they keep a counseling room. So pets, I have been in the practice for 25 years. Pets like a family members. The business is increasing day by day. So if you don't tell about the pros and cons, and the next day you cannot run your day-to-day activity because of the availability of social media. So give the pros and cons of the problem, then go ahead. So majority of your hemoprotein is causing a glomerular disease and result in glomerulonephritis. The most important thing is, it will also causes thrombosis, and there will be a blood clot formation in the renal arteries that will cause ischemia, and that result in renal failure, and that's the basis for most of the other issues. The intrinsic intrarenal causes, tubular injury, ischemia, and toxin, interstitial nephritis. Postrenal causes mostly is caused by the obstructions. That once it's obstruction, surgically you have to remove. Whether the feline urethral tract obstructions, or male dog having a caliculi, or the female dog having caliculi, you have to remove by surgically. Next slide. Again, histologically, how the changes are taking place. Next slide. Next. So the grading, as per CKD 2023 guidelines, So the classification of kidney disease in various stages. One, they are staging with the creatinine. Another one staging with the symmetrical dimethyl arginine, SDMA. The third, they are doing with the UPC ratio. And the fourth, they are doing with the blood pressure monitoring. And these are all the classifications. So what they are telling, suppose the dark creatinine 4, SDMA is, keep dark creatinine is 1.4. SDMA is 30 microgram per deciliter. You think is renal disease or you won't say renal disease? Any one of you? Any one of you? Because the 2023 update, that is the one they are insisting. So you have to take SDMA as a reference. Even though creatinine is normal, SDMA elevation up to 16 microgram per deciliter is normal SDMA. When the SDMA elevated, you have to think about the staging, because based on the SDMA, you have to give the treatment accordingly. That is the basis. Then GFR, we are not day-to-day practice, we are not able to estimate the GFR things. And then, stage 1, they have a normal function, and stage 2, mildly decreased functions, stage 3, moderately decreased functions, stage 4, severely decreased function, stage 5, there will be a kidney failure. Next slide. So, based on creatinine, grade 1, 1.6 milligram per deciliter, grade 2, 1.6 to 2.5 milligram per deciliter, grade 3, 2.6 to 5 milligram per deciliter. Like that, if a grade 5, more than 10 milligram per. Why this grading is very important? It will help you to predict the treatment. That's the reason I told, counseling to the owner is very important. Based on the grading, you can tell the owner what stage it is, accordingly you can treat. Next slide. So there are several biomarkers, and I tried with my student with the N-acetyl beta-D glucosaminidase, and we also tried with neutrophil gelatin associated lipocalin, and we tried with the symmetrical dimethyl arginine. Among the available biomarker, what the world state 2023, what they are recommending, you have to use SDMA as the reference marker, because that is the one, yearly it can excreted in the urine. So that you have to use as a reference marker in your practice. Next slide. Next. So once you identify the elevation of blood urea nitrogen creatinine, and these are all the symptoms you encounter in the dog with the cat with the renal failure: decreased appetite, weight loss, bad breath, vomiting and diarrhea, oral ulcer, weakness, lack of energy, and increased sleeping, increased thirst, and urine production. These are all the common observation you can. So what the message would like to insist is, kidney failure, you need to start from head to tail, because in eye you will have hypertension. There are occasions you will have a hypema, collection of blood in the anterior chamber of the eye. There are occasions, they become blind if you don't able to diagnose the hypertension on time. How many of you are having a Doppler BP in your practice? Just raise your hand. This is very, very important. So you cannot use ordinary BP machines, what they are using for human being, because in Doppler, wet Doppler, there are some software modifications. Even Rebecca Kirby, when she came here also, she insisted use of Doppler BP machine for diagnosing hypertension. So majority of the renal failure, they go for hypertension. And then you also prescribe the tablet, anti-hypertensive tablet like benazepril or enalapril to take care of the hypertension issue. If you don't treat the case on time, if the animal is having hypertension, that will go for multi-organ failure. So using a Doppler BP is very important in the patient with renal failure. Next slide. So evaluation of patient with the spectrum of AKI, the younger animal also they are prone to get when they are exposed to the nephrotoxicants. And then careful history taking is very important. Physical examination, check the hydration status is very important, especially chronic kidney disease. We give the ringus lactate for a couple of days. So CRT, how do you check? Buccal mucosa. Just press the buccal mucosa within 2 seconds, it will get the perfusion. It takes more than 2 seconds, you can think of dehydration. And similarly, heart rate, auscultation of lung, pulse quality, body condition is very important. Majority of the renal failure, they are going for become cachectic and emaciated. So body weight taking is very important. Urine analysis is very important. And then always check how much is the quantity of the urine animal is voiding. It is very difficult, but I have seen in abroad, what they do, no, they have a pad. So they put it below the dog or the cat, no, when they are critically ill. When they void urine, no, they take out the pad after when they are cleaning. They put it on the weighing machine. They can measure how much quantity of animal voided the urine. That's a pad also available. And then complete monitoring, you need to CBC, serum biochemical profile. And then nowadays you need how many of you are having ABG machine for your practice? You must have ABG machine, bedside diagnostic equipment. You need to have, very near to the patient. And then PCV, total protein, these things are very, very important. So coming to many senior, they can ask, see, CRRT, intermittent hemodialysis. Everybody cannot do in independent practice is very difficult. So what you can do at a remote place, at a general practice, what I can do with the renal failure patient, even though you tried with the various modality of the diagnosis, you tried fluid therapy, you tried various application of treatment, you are not able to control the uremic crisis. One of the option till date, pediatric patients or neonatal patients, human patient, child, when they are having a renal failure, they will not go for hemodialysis, they will not do a central line access. Become challenging. The another thing, what they do? They go for peritoneal dialysis. Till date, there are child peritoneal dialysis society available. What they do, for child having renal failure due to various reasons, uremic crisis control, they do go for peritoneal dialysis. What they do, the peritoneal dialysis solution, they infuse into the abdominal cavity by fixing the peritoneal dialysis catheter. And then the dialyzed solution, they infuse into the abdominal cavity. 10 ml every kilo body weight, they infuse. They leave it with the patient for 1 hour. Then after that, they drain. So with this process, a couple of maybe per day, 2 or 3 sessions or 4 sessions, if we can do, the uremic value, elevated blood urine antigen, creatinine will come down. The patient uremic crisis can be minimized, provided you have to identify the primary cause of the problem. Uremic crisis, CRRT or ISD is a managemental. You cannot bring back to normal position. So if it is a AKI, definitely you can bring back to normal position. And then what happened, the deficient solvent move by concentration gradient. So the higher concentration to lower concentration, ultrafiltration, the pressure exerted on this, the molecule will move. Here, the molecule osmosis, low molecular weight to high molecular weight substances, the things are moving. This is the basis for peritoneal dialysis, hemodialysis, and then continuous renal replacement therapy. This is the one I already told you. The indication, mainly acute kidney injury you can use, elevated blood urine nitrogen creatinine case, uroabdomen, metabolic abnormality, electrolyte abnormality. The most important, congestive heart failure, refractory to medical medicine. So your mitral valve disease or DCM, you are reducing with, you are treating the case with pimabendone, enalapril, metal, diuretic. In spite of this diuretic, if you don't, reduce the fluid overload, you can go for PD. With that also, you can reduce the fluid overload. In CRRT also, there is an option to remove the fluid without subjecting the blood for various modality. Only the fluid alone can be removed. There is a technique called SCUP. And then these are all the ingredients that are available in dialyzer solution. It's having dextrose anhydrous 1.5 gram, sodium chloride, sodium lactate, calcium, magnesium, and so on. That's also available in PPT. You can check it. It is readily available in human hospital. Those who are having nephrology, urology hospital, they have in their unit. You can get it from them. It costs about entire peritoneal dialysis technique. It comes less than 1,000 rupees. But day-to-day practice, we are not focusing this. And these are all the different catheters. You can see, there are fenestrated tube drain, silicone wound drain, and then column disc catheters. There are bent catheter. There are T-shaped catheters. There are different catheters. The people are working in human patient, especially pediatric child. And, they can leave it to the patient. There are permanent catheter. You can leave it to the patient for years together. If they are having a uremic crisis and is going for multi-organ failure, they leave it to the patient. Those things also available. And many of them, they have a patent. And I will go ahead quickly because other speaker has come. Now, you see this is the area you need to consider. I will restrict my talk only with the diagrammatic representation so that it will be in your mind for longer time. This area, you can make use of it, save the abdomen. complete sterility is very important. Like how surgeons, they're taking the patient for surgery. Like that, you need to keep yourself, be prepared, because you are going to the peritoneum. You should not interfere with the peritonitis, and that should not be a problem to the patient. So clean the area, apply some antiseptic. 1 to 2 centimeter lateral to the midline, you make a small incision. Normally what I do, I put a 16-gauge needle. Imagine the pointer is the 16-gauge needle I introduce into the abdominal cavity. Then there is a guide wire available. Then the guide wire I introduce into the needle. Then, with the needle I infuse the peritoneal dialysis solution. If it is not available, I use ringus lactate, IV, until the abdomen distant. Then I'll do a abdominal ultrasound. The abdominal ultrasound, I can able to identify the presence of fluid. It will be anechoic structure. And then I'll also move the catheter where exactly it's present. It should not hurt other organ. I will check that. Once I check it, then I will also attach a dilator, because from peritoneal region we are going to the abdominal cavity. The space, we have to create a bigger space. We make a bigger space. Then after that, the guide wire in position, the dilator I will move front and back. Then finally we'll fix the peritoneal dialysis catheter. Then with the Chinese knot we'll put attaching with the skin of the animal so that it cannot move. And then there is a device, there are separate jacket that are available for dogs and cats that you can put it around the body of the animal. And I told 10 ml every clear body weight you can infuse. And then you leave it with the patient for an hour. After that you can drain. So that the blood vessels that are present on the abdominal region, so the dialyzed solution goes inside. From the blood vessel, elevated blood urine nitrogen creatinine comes to the dialyzed solution. Once it comes available in the abdominal cavity, you can drain. And so this is the set. It's cost about 250 earlier, now is 350. And making an incision on the skin. And then introducing the needle, and then we fixing the peritoneal dialysis catheters. And then the positioning, we are checking with the X-ray. You can see the outside tube. So this also we have some work with some IIT professors. What they have done, instead of manually giving the fluid and leave it with the patient for an hour, and draining, you have to calculate how much we drain, how much it collected in the container. So one professor, what he did, he developed a device. It will, you have to fix. Suppose body weight of the animal is 10. So 10 ml every kilo, but 100 ml of dialyzed solution, it will collect from the bag. It goes to the abdominal cavity. You leave it, set the set time. The dwell time is 1 hour. Leave it with the patient for an hour. Then after that, you can drain. So everything, it can be operated by the machine. The same application, you can do it with your mobile phone. With the Bluetooth option, you can operate. So this is also we standardize, and they are using it for human applications. And this is the one, I told you. Normally, avoid taking the catheter into the cranial aspect, because cranial aspect, you have a bilobed liver. Normally, keep it, any part you can keep. Left side you go, you have spleen. If you go caudally, you have a lot of space. Normally, I will fix towards the bladder. And before fixing the catheter, I will see that the bladder is empty. How many of you can do a bitch catheters in dog, except surgeon? So you must learn hands-on technique. Bitch catheterization is very important. The animal which are not avoiding urine, that itself causes stagnation of urine. That will result in hydronephrosis. When you do an ultrasound, you will see a hydronephrotic kidney. That will result in multi-organ failure. So bitch catheterization, female, male, I know all of them you can do it. Female, the trick is the urethral opening, you have to desensitize by applying the lignocaine gel. Once you apply the lignocaine gel and avoid the animal should not be aggressive. So you can do it very easily. Maybe in the hands-on we'll see when we allot some emergency critical procedure. So you see the dialyzer solution we are administering in the abdominal cavity, leave it with the patient, then we are releasing. That is the purpose. And then, so these are all the various structures on the peritoneal region. And you can see a normal peritoneum, you will have a good mesotheliate cells. And then PD patient, the mesotheliate cell getting interrupted. And then you see, histologically, the urea and the creatinine from the blood vessel comes to the abdominal cavity. our dialyzed solution, including the dextrose, it goes to the patient. Most of the peritoneal dialysis patients, you need to check the glucose level every 1 hour or 2 hours. That's the reason you must have ABG machine very near to your procedure. You must have a Doppler BP machines very near to the patients. Though it's a simple procedure, but important procedure. These small equipment very important. Even the emergency critical care procedure in unit, it is very easy for me to convince the owner. When they come with an emergency, I will tell them the animal is having renal failure, the blood urine is this much, creatinine this much, potassium is this much. We are planning to control the values with the available protocol. They will be convinced. Instead of collecting the blood and getting the data tomorrow, then it will become your ultrasound now become a bedside ultrasound. Your echocardiography now it become bedside echocardiography. So all this category is very important for managing this type of patient. When you need to avoid, when the animal is having peritoneal adhesion, fibrosis, malignancy, you need to avoid. And then recent abdominal surgery, inguinal hernia, burn victim, extremely malnourished patient, you need to avoid this procedure. And this is after the healing, how the fibroblast looking at. There is a study, we have to estimate the pre-burn value, post-burn value, then pre-burn value multiplied with 100, you will get the urea reduction ratio. If it is less than 1.4, your procedure in the correct direction, your patient, it is also helping the patients. So other intermittent hemodialysis, CRRT, it is a high-end procedure, lot of expertise is needed. But this procedure you can do it. It is possible. You try with a couple of cases, and then then after that you can perfect in your procedure. And then I'll go to the simple technique. I told all the procedure will come less than 1,000 rupees. Compared to CRRT, ISD, we also do stem cell therapy for patients with renal failure. There are varying report, not subcutaneous or intramuscular administration. We administer stem cell therapy into renal artery. But even then, there are varying report we are getting. So the message is, high-end procedure possible only in the institute or in the bigger hospital. But the PD, it is possible in your day-to-day practice. Some of the practitioners in Karnataka, they do, but other places, yet to do it. And then intermittent hemodialysis, the basis, already I told, the blood goes in one direction, the dialysis goes in another direction. Maybe you can see this. There's a small fiber, through that only the blood goes. With the diffusion and convection and absorption technique, the blood urine nitrogen creatinine from the patient blood, it goes to the dialyzed solution. That is going in opposite direction. The clearance are taking place. Then the entire blood goes to the patients. This is the basis. And then the entire process from the jugular vein, I'm collecting the blood, purifying the blood, sent back to the patients. What do you think, some important step I must do? Anyway, every 1 hour, blood urine nitrogen, creatinine, potassium, I have to check. Blood pressure, I have to check. Apart from that, what do you think is very important thing I need to concentrate while doing the procedure? Anybody? Important, because I am taking the 250 ml of blood from the patient. From here, I am taking the blood, it goes to the machine, and then the artificial kidney tubing system, it should not clot. So every time what I do, I use 10 international unit of heparin into the circuit. So all the machines, they come with a ready-made, chamber to, mix heparin. This is the chamber wherein you can load a known quantity of heparin. For example, you are running the dialysis procedure for 3 hours. Loaded heparin 10 international unit per kg body weight. That means 10 kg body weight, 100 units it needs. 100 units every 1 hour should be given. There is an option available. You set it. So it will the heparin, goes into the circuit. So blood won't clot. This you have to take care of it, the entire process. And then I'll go ahead quickly. This is the way the exchange are taking place. These are all the asymptomatic conditions. And then central line access is very important. This is a straight double lumen catheter. There are bent catheter also available that you can use it. And there are small fine-tuned technique that are available. Even if you are using the procedure, tomorrow you perform the dialysis procedure, next day you want to do it, that means it should not clot. So heparin, you need to infuse. There is a, values available, 1.3, 1.4, they are written on the catheter itself, that we infuse so that, it won't clot. Next time, tomorrow when I want to do, no, I'll take out the apparent, then I connect the tubing system, I'll run the machines, it get purified. And then this is the state, and before 1953, any surgeon want to do any interventional procedure, they have to cupboard. Suppose I am having aortic stenosis, they do thoracotomy and they take out the, aorta, and then they rectify the stenotic area. Before this Seldinger technique, this scientist, till date, we have in his name only. Though we have another technique called modified Seldinger technique, it is available in his name. But small, he's a radiologist basically. What he did know, after this invention, jugular catheter is a small technique, but this will helpful for majority of the human interventional procedure. So what we have to do is, they have a needle, and through the needle we introduce this guide wire will introduce, and then after that we introduce this vessel dilator, thinner dilator, thicker dilator, and then we use a BP blade, making the space bigger. Then after that, we remove the needle, we remove the dilator, and finally, we fix the double lumen catheter. Then after that, we infuse heparin to avoid clotting. This is the basis. From here, because we do this, I am able to go to the right ventricle, I am able to go to the right atrium. Because we know the technique, from the saphenous artery, we are going to the femoral artery, and the femoral artery, we are going to the renal artery. And some of our students, they are going to administer the stem cell into the other parts of the place also. So the message is, the small technique, it will guide you to do all the other bigger procedures. So this is the way, the trained team is very, very important. So they're fixing the double lumen catheters. And the majority, this is our unit, and the majority of the renal failure patients, when they go for hemodialysis, they go for hypothermic. So we need to keep a good bedding materials, and the trained person should be available. Many times when I fix dialysis, my attendant technician, they'll go on leave, because lot of time consuming procedure, they won't be there. It's a lot of, so blood pressure monitoring actually is very important. Hypertension, hypotension, you need to correct. Otherwise, that will end up with multi-organ failure. And then I told it will also result in blindness. So ophthalmic examination is very important. This is the way we make the Doppler BP measurement. And then what we do now, we check the pedal artery. And then once we check the pedal artery, then we'll apply the cursor. After applying the cursor, now we check the beep sound. Then inflation monitor, we need to inflate. And then slowly we release the manometer value. Once you get that value, that is the systolic blood pressure of that particular animal. That's very important. Maybe hands-on, you will have much more information. Complication associated with it, it's a lot of complicating procedure, hypotension, dialysis disequilibrium. When I shift nearly 250 ml of blood to the patient, the dialyzed solution are going in the opposite direction. The mental disorientation we encounter in some of the patients. Actives, maybe drunken people, how they behave, like that they behave at the first sitting. After that, they used to that. Hemorrhage is another complication, because we are using heparin, bleeding will be there. Respiratory complications, gastrointestinal complications, blood clot, and then edema, malnutrition, anemia. These are all the complications we normally encounter. So, this is actually a statistics from abroad. Overall survival of hemodialysis patients 40% to 60%. But in our place, the delayed referral, so far, snake poisoning, viper bite, we saved successfully. Snake bite cases, we saved successfully. In spite of trying with the antivenom, the protein that are available in the venom that causes renal failure. That we can take out only by this blood purification technique. And some of them drug-induced renal failure, that's given wonderful result. Why we face a lot of, that much of success we are not getting? Because majority of our problem caused by hemoproteasome disease. Your Babesia zibzoni or Ehrlichia canis, Anaplasma platis, and these parasites are the alarming problem creating. Next slide. This is the high-end procedure. Even the corona outbreak, this technique very famous in human medicine. This machine available with us, nobody is having in India. And already I told, it's like a highly sophisticated machine. We are putting the jugular catheter and sending the blood to the artificial kidney, blood getting purified, and the blood then sent back to the patients. What happened in the corona patient or the patient with immune-mediated hemolytic anemia, when you want to remove the plasma, when you want to administer the new plasma, there is a kit available, that technical therapeutic plasma exchange. So once the blood goes into this therapeutic plasma exchange kit, it will remove the old, the patient plasma. We have to administer the newer plasma to another end. The same circuit, we have a provision. We can administer, we can save that type of patients. And that's the reason it's become familiarized in human patients when the initial outbreak of corona, because they remove old plasma, they administer newer plasma. After that, other standardized technique, they have for corona patients. And then main indication for CRRT, the list of procedure, the one indication, the smaller weight patient, you can make use of this technique. 3 kg patient, you can make use of it. 3 to 7 kg, you can make use of it. And then multi-organ failure patients, especially renal failure, with multi-organ failure, this equipment can be used, it's stable. This is the way, the blood, from the patient, it goes here. And then dialyzed solution is coming in another direction. The plasma exchange, you see the yellow color is the plasma exchange removing area. There are 4 modalities. Quickly I tell you: slow, continuous ultrafiltration, congestive heart failure patient, volume overload. In spite of diuretic, you are not able to control the fluid overload. There is an option available in CRRT machine called SCUF. You just select the machine after putting the jugular catheterization, sip the blood, how much quantity of fluid you want to remove, just fix it, you can remove it. Then continuous hemofiltration. So when you are removing the fluid, you want to administer a certain quantity of electrolyte. That is possible with the CVVH technique. And then CVVHD is like a dialysis mode. That is also available. CVVHDF is called diffusion and ultrafiltration technique. Smaller molecule, like creatinine, moderate molecule blood urea nitrogen, poisoning chemicals, everything can be removed with this CVVHDF mode. This is the most suitable modality mode for a 3 kg to up to 10 kg patients. This is the SCUF mode, blood is coming and then fluid removal you can see. CVVH, whatever the fluid removing, you are replacing with the replacement fluid. HD is a dialysis mode. The CVV HDF, how much the fluid you are removing, that you have to replace with the dialysate and replacement solution. Is safe for smaller patients. That is the conclusion I would like to tell you. Comparing with the intermittent hemodialysis and the CRRT, is intermittent hemodialysis machine you will get per 7.5 lakh. CRRT machine costs 15 lakhs. The cartridges available for CRRT is about, anywhere around 20,000 you need. But intermittent hemodialysis may be up to 7,000 the accessory cartridges that are available. And this is the therapeutic plasma exchange and how the plasma being removed. That's all about the entire process of hemodialysis. Any questions, any interaction, you can have it if the organizer permit. 1 or 2 questions? Yeah. Yes. Yes, sir. Snake venom, sir. Snake venom that contain lot of protein. That protein causes renal failure. Snake venom. People, they try with the anti-snake venom. For example, 10 kg body weight, they give 1 dose of vial. The 1 dose of vial, human patients, what they do, they go for 3 to 4 vial of anti-venom. But here, we go with 1 vial or maximum moderate size dog, they go for 2 vial. So, in spite of giving this type of higher dose, patient end up with renal failure due to snake envenomation. You can very well take care of with this technique, ISD or CRRT technique. Because that venom protein can be filtered with these filters. That is the concept.
Thank you, Dr. Chandrasekhar. Now we are running short of time. Now if at all any questions, Professor will be here for the next 2 days and definitely you can take it from him. And thank you, Professor. You have elaborated it on the hemodialysis and even peritoneal dialysis which is possible in the field side. Thank you. So our next program, sorry, we have a change in the programs because some of the speakers couldn't come in the time because of their previous assignments. And the next topic is on access to vet care. What is the low-hanging fruit in the humane dog population control? It's going to be given by Dr. Ilona Water. Again, most of us know about Ilona Water, and she is the Director of International Veterinary Training, WVS. Probably nowadays, WVS is catching up more with the younger vets than the older vets also. And definitely we are introducing you to the older vets also, madam. And many of them are interested in the ABC programs in your, and also the other training programs which we will circulate among our members. I request Dr. Ilona Water. Yeah.
Okay, so thank you very much for the introduction. I'm suffering from a severe loss of voice, so just please be patient and trust that this is not my regular voice. If you come to our training, it'll be much more pleasant listening to me. So I assume most of you are from private practice backgrounds, and you might be thinking, what is it with APC programs and dog population management that has to do with private practices? Isn't that something that charities are doing? And I hope that this presentation, I'm just going to have a strepsil on the way. Excuse me. I hope that this presentation will help you to maybe get some new inspiration in how your private practice can also be part of this. And whoever is very interested at the end of it can come and ask me, and you'll get a nice wristband to mark that you are part of this gang. Okay, so, so access to vet care, what do I mean with that? It's kind of a campaign that as WVS we have, launched earlier this year. And in association, I like to use the expression, the low-hanging fruit. Because whenever we have a problem, there is usually the first part, the low-hanging fruit that we should be achieving and aiming to achieve first. So, nothing is happening where I'm supposed to direct this. Okay, happening. So access to vet care, maybe I speak to this. It's an awareness campaign. Is this on? It's a surgical experience program, and it's a spay-neuter program. And as I said, I want you to see and learn how private clinic vets can benefit from active participation in humane dog population management. Now, the awareness campaign part is really about understanding that in India, we have a lot of owner dogs that are allowed to roam free. And I'm not talking about some whatever community dogs, whatever people mean with that. I mean actually owner dogs, pet dogs, that are allowed to roam free part of the time, full time. This is especially true in small towns and villages. And also in these places, in small towns and villages, there may be generally lack of access to spay-neuter surgery services. This will result in unwanted pregnancies among those owner dogs, unwanted puppies being abandoned, and those puppies becoming more street dogs. Responsible ownership is obviously something we all talk about, but what belongs to responsible ownership? Thank you so much. And how well all owners can actually do that. We have to think, are all owners actually having access to spay-neuter services, irrespective of their socioeconomic status? So spay-neuter is not only about NGOs, and it's not only about stray dogs. Okay, I don't know why this is. Am I doing something wrong? Okay. So definition of a pet dog or owner dog is not based on a pedigree of the dog. It's not based on the socioeconomic status of the owner. It's not based on the owner having a house where a dog can be confined. This is my dog. Sorry. This is my dog, that is my puppy, is really all what matters. sorry, now I was too strong. Somehow I'm not able to do this correctly. I want the previous slide. Yeah, this one, thank you. So, ABC Rules 2023 that deals with all the legal guidelines for government funding used for sterilization of stray dogs has this clause, clause number 8, that says that the responsibility for vaccination and sterilization of owner dogs is with the owner. But we can only expect owners to be responsible and do this if they actually have access to affordable spay-neuter surgery. I don't know. So, as a spay-neuter program, what I'm talking about is targeted and focused owner dog new spay-neuter campaigns. And if you have got the idea that like ABC program requires some shelter and dog catching vehicles and kennels, now I want you to forget all that. Because when you're running a targeted owner dog spay-neuter campaign, you don't need dog catchers, you don't need dog catching vehicles, you don't need post-operative kennels, and you don't need any feeding and cleaning of these dogs, because the owners bring them, owners take them away. You can use any existing facilities for temporary high-volume campaigns. These might be government veterinary dispensaries, these might be some school buildings, community halls. I'll have some videos about those. Basically, you are taking the service in a campaign manner close to the community that you are targeting. So basically, sorry, I think there was, okay, fine. Sorry, this is not going very smoothly now. Next, please. I don't know. It's just not happening. And of course, for us, as WVS India, we are very focused on teaching and providing surgical skills experience. So what we've been also doing is that we've been doing these kind of clinics, targeted owner dog spay-neuter clinics, where we have taken participants, veterinary internship students or other veterinarians, to learn surgery along the side. So that again, like for example, this picture is from a government veterinary hospital in Kerala, in Alleppey. And the participants here are from the animal husbandry department of Kerala. So they've come to do this surgical training program in another government veterinary hospital, operating owner dogs that are brought in by their owners. So every step of this program is something that they can implement in their own hospital. They can really see the full thing from how the owners come, how they are sort of registered, how the surgery happens, exactly in the same kind of hospital rooms than what they have access to. And so they can, take this program and continue it in their own hospitals. Having basic surgery skills is also so important for doing so many other procedures that any small town government veterinary hospitals might come across with. During this particular program, there was a goat with no, it was another place, but yeah. Anyway, there was a livestock surgery. I mean, there was a male goat that came for a urinary obstruction that had to be operated. It was just an example of a surgical procedure that might be needed, that might require treatment at the government veterinary hospital. So emphasizing the need to have good surgical skills across the veterinarians, regardless of
Puppies and dogs can trust Drools Focus. This is because Drools Focus is a specialized dry food that has all the good stuff. Real chicken, whole rice and oats, vitamin C and E, minerals, probiotics. What it doesn't have is wheat, corn, soya, fillers, or any artificial colors and flavors that add unhealthy weight or hamper growth. Focus is especially important for puppies
Right,
as
okay.
it contains
So,
all the right ingredients
Now,
essential for
what
growth,
about
muscle
private
building,
clinics?
and
So how
immunity.
do private
Good for all
clinics
breeds
come
and
into the
sizes, this
picture?
formula is packed with
So
pure
these
taste
kind
and
of
goodness,
campaigns
more meat
can be
and less grain.
implemented as your CSR
You see, Focus is
activity,
all the nutrition,
as
attention your
sort of
little
team
pooch
building
needs.
activity.
Besides,
you
of
know,
course,
if
the
you
never-ending
are
physical
moved to
attention.
that bigger hospital.
Drools Focus. Feed real,
In America,
feed
they
clean.
use term MASH type clinics.
Watching your
which
little
comes from
pups
the
grow
words
into big
mobile
boys is a
animal
bittersweet journey.
sterilization
They need
hospital.
love,
In
attention,
India,
yes, and
whenever you
focus
say
at all
mobile
stages.
hospital,
And while they
people
change
tend
and
to
evolve,
have the idea
their food
that
needs to
it's
evolve too.
difficult
The
to
Drools
train
Focus
them.
range is built
But I don't
exactly
need
for
that,
this reason,
because
to
to
give
be
them
honest,
the best of everything at all ages. For little pups, it's more meat and less grain starter formula. For growing pups, there's a corn and wheat-free formula with real chicken in crunchy kibble. And for our adult dogs, it is a specialized dry food packed with real chicken, vitamins, long grain, rice, oats, and probiotics. Drools, feed real, feed clean.
Sometimes your fully grown dog might insist on sitting on your lap like he's still a little puppy. But he can't be fed what he used to as a pup. Your dog's food needs to evolve as they evolve. And we have just the right food for every stage of their growth. The Drools Focus range has a more meat and less grain starter formula for weaning pups during the period of 3 weeks to 3 months. A corn and wheat-free formula with real chicken and crunchy kibble for the growing puppies. And specialized dry food packed with real chicken, vitamins, long grain rice, oats, and probiotics for our adult dogs. But basically our overgrown puppies.
This can, of course,
Drools. Feed real, feed clean.
If they have these kind of
You know, guys, everyone thinks I love myself the most in the world. And you know that's slightly true. But seriously, I love my dogs, Fudge and Astro, way more. Which is why I give them nothing but the best. And that's why I only feed them yummy Drools. Did you know Drools contains 100% real chicken, chicken liver and eggs with zero byproducts or fillers. And it's packed with all the nutrition my dogs need every single day. Wait, there's more. I did my full homework on Drools, let's see. Drools improves a dog's digestion, immunity and coat. It's great for stronger teeth and bones. It's got kibbles to prevent tartar. There's a vegetarian version and a special recipe for puppies. And, oh, that's it. Yay! Drools Daily Nutrition. Feed real, feed clean.
So how do you go about it?
You know,
As a
guys,
parent, it's my topmost priority to make sure that my children are getting the most wholesome nutrition. And that goes for my furry baby too. With Drools, you can be sure that your pets are getting their daily intake of essential nutrients and real ingredients. Made with 100% chicken and eggs, zero fillers and byproducts. Drools Daily Nutrition is every pet parent's go-to. Drools truly meets my main criteria. Real ingredients, and real ingredients. Drools. Feed real, feed clean.
So you collaborate with some group that has good rapport.
Today,
with
I
the-
feel like
with the
eating
residents
simple
of
home
the area, so that
dal
they
chawal.
advertise
No, Aryan can't have that.
the service
Just like
that you
Aryan has a
provide.
different doctor, different routine, and a different lifestyle. He has different food needs too. So he can run and play around, digest his food properly, have a lustrous coat, and not have to go to the often. Drools Daily Nutrition is packed with real chicken and egg, and no byproducts or fillers. With minerals, vitamins, and antioxidants, it's a complete and balanced diet that no homemade food can provide. Give your dog the best. Drools, feed real, feed clean.
They took the registrations from all the owners. We had.
Hi guys, meet my love Posh. I fell in love with her in 2014. She was actually a rescue cat. Needless to say, I love Posh a lot, and sometimes she loves me, but I don't think that she loves me as much as she loves something else. This is what she loves, Whiskas. Posh loves Whiskas so much that she can literally do anything for it. And do you know that this is the same for every cat out there? Whiskas is #1 cat food in 25 countries. Wow. Cats just love the taste of Whiskas and the delicious range it has. Pata hai, even I love Whiskas. Not only me, every cat parent I know loves Whiskas because it has all essential nutrients which cats need to be healthy from inside and shiny from the outside.
Yeah, so just because you're operating on the field or outside in some temporary location, it doesn't mean you're doing it badly. It doesn't mean you're doing it somehow with poor quality. You can still do it well. Here is another clinic. We're just setting up a clinic. So everything is brought in. Positive publicity, team building, CSR, marketing, new clients, junior vet skills development. Who wouldn't want that? You can do it even sort of outdoors. This is in front of a community hall, also in Bailakuppe. Again, mass type clinic means we have a vehicle, and with that we transport all the equipment we need. We do not need to operate inside the vehicle. That is often unpractical. Or more unpractical than this. So you plan high volume campaign days, so you can be prepared to operate something like up to 20 dogs per team per day. For example, what we've been doing is a team that consists of 2 vets, 3 to 4 assistants, one of them is a driver, and they will deal with the surgical preparation, anesthesia monitoring, instrument cleaning, and autoclaving. Then we may have had some volunteers from the local community group to take the owner consent forms and provide, post-operative instructions to them. And we've given post-operative oral eloxicam. High quality, high volume campaign days. And now, coming to the finance part of it, this does not need to be free for the owners, okay? So you can set your price tag as per the target community. Most people in small towns and villages cannot pay 10 to 15,000, which may be a set spay-neuter charge in bigger hospitals in cities. But most people will be able to pay 1,000 to 2,000 rupees for the surgery. So if you plan a day to do 20 dogs in a day, you can have an income of 20 to 40,000, which will then cover your expenses for that day. So this is not something you have to do from your own pockets. Obviously, if you have some local sponsor, great, that's good. You can do even more. But this doesn't need to, I'm not necessarily talking about this being free, just that it has to be affordable. And it can be made affordable when we plan high volume campaigns. We have some local volunteers who are giving instructions. So they get the vaccination card, they get written instructions and we've been also doing follow-up calls on the day 3rd or 4th after the surgery. This is the audio. This is one owner giving a feedback of the surgery experience. There's a consent form. So again, just because you're outside of your fixed hospital, you still keep it professional. Consent forms, that kind of communication with the owners. So the owners have exactly the same experience as if they came for your private hospital in a city, just that they're doing it in their community and it's more affordable for them. I can press it.
So yeah, this is our first time with being a pet owner. So surgery, I wasn't really familiar with surgery, so and it was really nice. It was very quick, just like it was expected. We were supposed to schedule ahead of time. We were supposed to give a list of how many dogs we had. So I gave my list. I said I have 5 puppies and 1 mother. I gave them the names. And I went on the day I was told to go. I met the team, Dr. Ganesh and his team, very professional. They asked, it was very, very thorough as well. I was asked for a name of each dog, what kind of breed they were, and I had to give consent for the surgery, which I thought was very professional, and you don't see that, And I was even telling my friends, I feel like the way they track and the way they collect data is better than actual hospital for humans, right, that we go to. So it was very nice and professional. The surgery went really quickly. Yeah, I had 6 dogs that they did surgery. I think that was very quick. Recovery was very well. I think, yeah, after they woke up, I think in a couple of hours, they were walking. The next day, we just were given a tablet, so I gave them half of the tablet. Recovery was very quick. Yeah, there was no infection. I mean, you can see the puppies, their mom, and they're all doing very well. No, yeah, everything was just very magical. Everything went so smooth. I am very thankful for everything.
Yeah, so now those of you, especially the seniors who own bigger private practices, so just to kind of, think of these things. Are all the vets working in your clinic able to handle a cat spay, initial surgical debridement of a traumatic wound, mammary tumor surgery, GDV? Are all vets working in your clinic able to handle sedations for these various situations? And with better routine in the above across all the members of the team, do you think your clinic could benefit financially? Then to the government veterinary sector, I believe there will be government veterinarians here as well. So we have this one example here from Aleppi district in Kerala, where we recently, in September and October, we ran a couple of programs like this in collaboration with the animal husbandry. And they have this plan to make Aleppi district rabies-free and that all owner dogs should be sterilized in 3 years of time. They have a pet registration going on there very well. So you see, they are not just banging their heads as in what to do if we don't have dog catchers and kennels and NGOs. They are focusing on getting the owner dogs done. And this is kind of the low-hanging fruit, which I mentioned in the beginning. They are also talking about, they already have the provision to employ vets for mobile veterinary surgery services, again, not necessarily operating inside a vehicle, but having a designated veterinary team that would go across the district to different hospitals and then run these type of owner dog campaigns, which I think is an excellent idea. And this is also a chance for veterinary internship students to get surgical experience during their internship, because if they come to this kind of hospital, this kind of government hospital which is having such a program, then that provides them an additional chance to learn surgery during their BVSC studies. So this is kind of an upstream solution. So at the moment, we have mainly these 2 options. We have when it comes to spay-neuter, we have the high-end 12,000–15,000 rupee surgeries. And then we have the APC programs with government funding for street dogs. But there is a huge population of owner dogs that are not covered by either one of these. And this is where we need to now build a bridge and to fill this gap. And this is where private vets can very much come into the case. And as an upstream solution, so we have, these are problems, these are symptoms of a problem. Everybody's reading newspapers, everybody knows we have a lot of dog bite cases, dogs on the streets are suffering, and there are rabies cases. So these are all symptoms of an upstream problem, which is the large free-roaming dog population. However, the large free-roaming dog population in itself is a symptom of something else further upstream, as well as these. Oh, okay. And these are symptoms from the upstream problem, that is the lack of access to spay-neuter surgery services. But the lack of access to spay-neuter surgeries is also a symptom of something further up. And that is simply that there is a lack of vets with surgical skills, if you think across the country and all over. Okay? Now, where do vets mostly, what is the best place at the moment, or the best kind of opportunity for vets to learn surgery skills in spay-neuter? And I don't mean WVS, I just mean generally. What type of employment where you learn surgery skills quickest? Mostly it's ABC programs, right? Because of the volume of surgeries. So young vets, if they work in ABC programs, that's where they can get a good amount of surgical experience in spay-neuter. However, ABC programs don't exist all over the place. And what is the reason? What is one of the reasons why they may not exist? That is a lack of skilled dog catchers. Now, the question, I mean, we are all veterinarians. Do we want our professional development to be depending on whether there are skilled dog catchers? Like, that cannot be the reason that's blocking the veterinary sector from developing in their surgical skills, especially looking at the younger generation. Okay? So when we have lack of skilled dog catchers, we have lack of effective ABC programs for stray dogs, and that means vets are not getting jobs in ABC programs. And again, we have issue with the free-roaming dog population. But if we focus on owner dogs as the low-hanging fruit and do these things that I have now been talking, that creates opportunities for vets even on a part-time basis to be able to maintain their surgical skills, even if they are working as microbiologists, you know, like even you have a lab job, you might be able to maintain your surgery skills because you might be wanting to set up a private practice one day. So there are so many reasons why this might be interesting to vets in different stages of their lives. So what I want everybody to remember is that humane dog population management is not only about NGOs and not only about stray dogs. Private sector and animal husbandry department can have a very important role to play in this. All owner dogs, regardless of the owner's socioeconomic status, should have access to annual rabies vaccination and affordable spay-neuter surgery. Affordable, not necessarily free, but affordable. What is affordable to different people is a different matter. And remember that with this access to vet care, if you've noticed, I purposely avoid talking about ABC program because ABC program is associated with government funding and street dogs. I'm talking about owner dog spay-neuter programs. For that, you don't need dog catchers, you don't need kennels, you don't need any of that kind of paperwork. Any qualified vet can operate and offer spay-neuter services for whatever price you feel suitable to dog owners, right? And WHO has launched this campaign called and target called 0 by 2030, which means an Indian government has taken this as a goal for India as well. So this means there should be no dog-mediated human rabies deaths globally, including India, by 2030. Now, technically, this target can be achieved by the human medical sector alone. If they just go on vaccinating and making sure every dog bite case gets vaccinated, this can be achieved. However, maintaining that only through the effort of the human medical sector is not sustainable. To control the rabies at source, which may be the next hashtag, control at source by 2035, will require veterinary intervention because it's in the end, it's the dogs that we need to be vaccinating and it's the dog population that we need to be managing. And this is a responsibility for the entire veterinary sector, not only those working in charities. So thank you very much for listening my horrible voice. I hope I'm kind of in time. And I'm sorry, if there are questions, I'm very happy to answer. And as I said, if somebody is very interested in doing this and wants to go home with this little souvenir, then we have these access to vet care wristbands I will give you. Thank you.
Thanks, Dr. Ilona. Definitely there needs to be a change of neutering the household pets. Definitely which will be easier to catch. But at the same time, the awareness among the owners also have to be created. And we vets have that, we have to do that. Awareness has to be created among the pet owners to neuter their dog. And now we break for tea. Tea is provided in the ground floor in the exhibition hall. And exactly 20 minutes, I request you all to come back to the stadium. Yeah, thank you.
You know, guys, everyone thinks I love myself the most in the world. And you know that's slightly true. But seriously, I love my dogs, Fudge and Astro, way more. Which is why I give them nothing but the best. And that's why I only feed them yummy drools. Did you know drools contains 100% real chicken liver and eggs with zero byproducts or fillers. And it's packed with all the nutrition.
With drools, you can be sure that your pets are getting their daily intake of essential nutrients and real ingredients. Made with 100% chicken and eggs.
Good evening. Now I would like to welcome Dr. S. Venkateshwaran. So youngsters, there are many people are there. You must know about him. With his undergraduate, I know he is able to handle his practice like a diplomate level. Some of them are they are in the group. Most of his videos is in-depth information about the dermatology. And his daughter is also a vet. And there are 3 people joined together, they're running the practice. It's very unique. Majority of the practice, this combination, it won't help, but they have been running successfully. And sir, you would like to talk about sex hormone dermatosis in canine. Now I request Dr. S. Venkateshwaran to take over the stage.
Again, one more good evening. Now, in fact, as Professor said, no, I'm not of that caliber belonging to the academicians or the university officials. I'm a just field level veterinarian only. Normally, now I will be asked to do these type of works to fill up the gap. Supposing all the professors, when they are not available, I will be given one shot so that people also can have a relaxation. Now, earlier days, probably in my days of cricket in West Indies, when Joel Garner, Colin Kraft, Andy Roberts, everyone comes and bombards, there will be a relaxation in the way of Vivian Richards bowling 1 or 2 overs. So in that way, I will be one which will be suiting to the gap. Anyhow, on this particular topic, now why I selected sex hormone dermatosis is, we get many cases, almost like 2 to 3 cases of sex hormone dermatosis I see in my clinic. But when you go to the book, invariably they say it is rare. But most of the books and the authors are from the countries where the spaying and neutering is being done at a younger age, where they will not be encountering such type of dermatosis or the other excess hormone problems. They may not be encountering it. But in countries like India, where we don't have much of a spaying and neutering, definitely they should be of more importance. Next. Yeah, in the sex hormone dermatosis, the major one is the testosterone, estrogen, and progesterone. Testosterone is normally secreted by interstitial cells of the testis, zona reticularis of adrenal cortex. And then as far as estrogen is concerned, the ovarian follicles, zona reticularis of adrenal cortex. Again, when the testicular is having the sertoli tumor, they also produce estrogen. And then in the progesterone, as you all know, the corpus luteum produces progesterone and zona reticularis of adrenal cortex. You might have seen adrenal cortex produces all the 3 hormones. They also will cause a problem, which of course we will be seeing it in the next few slides. So next. So in the sex hormone dermatosis, the major ones are hyperestrogenism, estrogen responsive dermatosis, hyperprogesteronism, and hyperandronism, which is excess testosterone, testosterone deficiency, which is testosterone responsive dermatosis, and then the last, adrenal tumors or the adrenal enzyme deficiencies. And this paper, now when I was looking into that, I saw this paper from our own university. The chief author, main author is Dr. Selvaraj, and then the co-authors are SRS, AP Nambi, and our Murali Manohar. Now in this article also they say, out of the flank alopecia, now because normally in sex hormone dermatosis we will be encountering only flank alopecia. Out of some 336 dogs with the flank alopecia, they have found out almost 185 were found to have endocrine involvement. That is, more than 50% of the flank alopecia almost come to this category. And in that, they have given the higher one was with sertoli cell tumor, followed by seminoma, and then the least is interstitial tumors. And the last one in that, that was the one which is not a surprise, of course, everyone. The owners in the study were unaware of their problems. Even in our practice also, probably you might have seen, when you say that your dog is a unilateral cryptarchid or it is bilateral cryptarchid, invariably 99% of the owners, they will be knowing it only at that time that their dog is deficient in having it. So it is also our duty to tell them in the initial stages itself that your dog is having an unilateral cryptarchid or a bilateral cryptarchid, and then how to go about it. That also it's our duty to explain to the owners. Next slide. Varling, sir. Yes. Sir, the previous. Yes. Okay. And in the hyperestrogenism. Now in that, you will encounter both. The male and the female also will have the hyperestrogenism problem. And then we will deal in the male. In the male, the hyperestrogenism is mainly due to the sertoli cell tumor and partly by seminoma. And the third one, this also, because the pet parents, they may be undertaking a treatment of using estrogen cream for their body, and the pets went the habit of licking the pet parents, and from them also they get this hyperestrogenism. And then in the hyperestrogenism in the male, the normal dermatological lesions, you can see the alopecia. Alopecia in the collar region, and in the rump. The rump is the space between the tail and the hip. And then the perineal region also, you'll have that alopecia, and the caudal ventrum. See, in all these things, you will see one thing. They will not have a problem in the head and in the extremities. This is the difference which you can see from the other dermatoses. Sir, next slide. So in the hyperestrogenism, as far as male is concerned, apart from the dermatological conditions, the other things which you can go in for a diagnosis is gynecomastia. The enlarged nipples will be there. The change in micturition. The male dog almost will change their position to go for the urination, squatting to the ground level, passing the urine as if it's a female. And the macular melaleusis, that is, the melanin pigments are more in the ventral abdomen, which I have the pictures, which I will show in the next slide. The preputial linear erythema. So in that also, from the scrotum to the penis, you will have a linear erythema, or even erythematous patches also you will be seeing it because of bone marrow suppression and aplastic anemia. Next, sir. So you can see this, the preputial linear erythema. That is from the, you can see that line, it's a very prominent one. Actually, this dog came to us for a general checkup only, and then we found this, and then later this dog had the sertoli cell tumor. Then the next you can see the linear erythema. And then this is the macular melanosis. You can see them, the black spots in the ventral abdomen. So these are all the clumping of melanin pigments, one of the common symptoms of hyperestrogenism. And then in the female, that we saw in the male. As far as the female in the hyperestrogenism, the main causes are ovarian tumors, ovarian cysts, ovarian estrogen overdose when we go for medical treatment, and then the same pet parents topical application, they also can cause it. So that you can see the ovarian tumors, and then you can see the enlarged nipples, and then the vulval lips also will be swollen. Apart from the dermatological lesions, you can see them as far as the hyperestrogenism in the female, in the post-auricular, below the ears, and then in the flanks, perineum, caudal ventrum, and then comedones also will be seen in the ventral abdomen like a hyperadrenocorticism. Next. Okay. As far as the physiological conditions, apart from the dermatologicals, you can see the swollen vulva, enlarged nipples, macular melanosis will be there, and they will be attracting males without coming into the periods. Next, sir. Yes, as far as in the hyperestrogenism, both in the male and female, apart from these alopecia, which are the beginning one, the secondary ones, you can see the seborrhea of ceruminous otitis, even the ears also will have the problem. Hyperpigmentation, after the alopecia, the skin will go for a hyperpigmentation and lichenification also. And you can see the pictures here. The next, sir. And then the next we can come to the hyperandrogenism. Hyperandrogenism is mainly due to the interstitial cell tumor. Seminoma also may cause it. Adrenal tumors also may cause it. In the physiological conditions, whenever you encounter hyperandrogenism, you will have perineal tumors around the anus, and in the perineal region you can see tumors, hepatite tumors, tail gland hyperplasia and alopecia, which is very common. So this type of things you might have seen in most of your cases. The dogs which are more than 5 to 6 years old, they will have an alopecic patch in the tail, and then even hyperplasia, a swelling also will be there. And with the swelling, as far as the hepatite tumors are there, you can even see a light bluish violet coloration of the skin also. And then the over-aggression, because of the hyperandrogenism, the over-aggressions also will be there in the males. Perineal hernia. Perineal hernia invariably with the interstitial cell tumors, the prostate enlargement is also there. The tenesmus leading to perineal hernia, both unilateral and bilateral. Next. So in the hyperandrogenism, as far as dermatological lesions, you can see them in the alopecia in the collar area, alopecia in the rump, alopecia in the perineum, and in the ventrum also. Next. And then the estrogen responsive. The estrogen responsive, we can see it in both the spayed ones and then the intact ones also. In the spayed ones, mainly in young adults you can see them, but the alopecia is rare. But in some of the dogs with the short coat, you can see the alopecia in post-auricle, ventral, and perineal. And in the long coat, alopecia will not be there much, but you will see the loss of primary hairs, the thinning. You can see the density would have lost, and then the thinning of the hairs will be there, mostly in the flank region. The next slide. And the estrogen responsive in the intact animals. Again, the dog is in that. Invariably, this is due to prior to coming to the first period, during the pre-puberty period, and during the pseudo-pregnancy, and in the estrous cycle abnormalities also. And when the dog has gone in for a pseudo-pregnancy, you can see them, a loss of heavy hair, telogenic deflections will be there, and then leading to loss of the primary hairs, the thinning of the hairs you can see, and you can even see an alopecia also. And then the estrous cycle abnormalities, again in that also you can see the alopecia. Next. And then the testosterone responsive. The testosterone responsive are normally seen mostly in castrated males only, which are middle-aged to old. The truncal hair loss, again the truncal hair loss only will be there. Dull, dry, flaky hair coat will be there. Change of coat color, this also you might have seen. Even in most of the roadside dogs which are neutered, the male ones you can see the coat color changing it. Part of the coat will be changed and the part of them will be retaining their original color. So that also you can see them in the testosterone responsive dermatosis. Next. And then in pseudo-pregnancy also you can see alopecia, mostly in the older cycling bitch. Alopecia will be there in the collar, rump, and perineum, ventrum. And in these things only they regrow spontaneously. Once they come to the next period of the cycle, the hairs regrow. So during pseudo-pregnancy, it will be a temporary loss of hairs only, not like the other ones. You need not even have to go for the treatment. Once the cycle is completed, the hairs regrow. And again, they relapse in the next cycle also. When you have the records of the owners who come to you very regularly, you can see them once in 6 months, they will be having these problems, which is mainly due to the pseudo-pregnancy, which is relapsing with every cycle. Next. Yeah. And then the differential diagnosis. Now, because alopecia is there almost in every dog has that problem. So to go in for the differential diagnosis, you have to differentially diagnose with hypothyroidism and hyperadrenocorticism, which are also very common. Both of them also will not have the problems in the head and the trunk. I said in the hormonal ones, you don't have the problem in the head and trunk. Even in hypothyroidism and hyperadrenocorticism also, you will not have it. But in these two cases, the alopecia starts in the trunk, whereas in the sex hormone dermatosis, the alopecia starts in the perineum. So when you ask for the history, where exactly these alopecia started, and from the history you can get a differential diagnosis. Of course, biochemically or with the blood test and other things you can differentiate, but even from the history you can differentiate whether this is due to sex hormone dermatosis or from the hypothyroidism or hyperadrenocorticism. And sorry, this hyperestrogenism should not come. The previous slide, sir. And then in follicular dysplasia also. Now again, it's an autoimmune disease. That also you have to differentiate. Of course, trichogram will help you in differentiating, and with the other tests also. And some of the breeds like Dachshund, they have the specific pattern baldness invariably below the ears and other things that you have to differentially diagnose. And the last one is canine atopic dermatitis. Of course, in canine atopic dermatitis, you will have more of the lesions in the ears and in the digits, which should not be there in a sex hormone dermatosis or with hypothyroidism or hyperadrenocorticism, which is one of the major ones which will be differentiating it. And then, as I said, again, between sex hormone and the hypothyroidism and the hyperadrenocorticism, where exactly it started. The truncal alopecia will be there in hypothyroidism and hyperadrenocorticism, whereas in sex hormone dermatosis, the alopecia starts from the perineum. Next, sir. And these are all the pictures, of course, that will be there in that. You can see them. Next, sir. And then when coming to the diagnosis, now invariably, as I said, alopecia, the hair loss, which is a major problem, invariably every day, most of the owners will be complaining you that my dog is shedding hairs, my dog is shedding hairs. But the shedding of the hairs is different from alopecia. So alopecia means you have more leading to bald patches or the thinning of the hairs. So in that, now when you go for that, you can see the asymmetrical testis, you can see the. Okay. So the previous slide. See the links are at today. Next. Yes, okay. So in that you can see the asymmetrical testes. So many of the times you might have seen them. The testicles will not be of a uniform size. One will be larger and then one will be smaller. Invariably the larger one will be tumor, and because of that the other one will be smaller. Say like in Sertoli cells, when the larger one, because of the estrogenic influence, the other one would have become shrunk. Now even you can see them even when they are cryptarchid also. The descended one, when it is reducing in size, you may have to think of the one which has not descended, which is retained, should be growing in size, becoming a tumor. And then you can even see the palpation. By the palpation also you can see them, the hardened ones, the tumors will be the hardened ones, and then the pale mucous membrane and petechiae because of aplastic anemia. And then the diagnosis can be done with the radiography, ultrasound, laparoscopy, and the cystic ovaries and tumors also can be diagnosed by them, the retained testicles and the metastasis. When you go for these ultrasound and the radio diagnosis, but as far as these testicular tumors, most of them are benign only, less than 10% only go for a metastasis, but the metastasis also can be diagnosed if you do ultrasound or the radiography. Next slides. And then even cytology. Even with the cytology also you can find out. For these things you have to go for a preputial cytology. You can take a clear sterile swab, insert it into the prepuce, take a swab out of it, stain it, and then you see. But initially they used to say earlier, the carnified cells, like what we see in vaginal cytology, when we decide for the crossing, when we see more of carnified cells. Even here also, when the carnified cells are more, you can invariably relate it to the Sertoli cell tumor, or even a prostate tumor also will have this preputial cytology with the carnified cells. Again, the superficial cells also, I'll be showing an article in the next one. When the superficial cells are also more, it also related to, they have found out using a study that more than the levels of estrogens are present, and the dogs correlate to superficial cells in the preputial cytology also. Again, this is also one of the diagnostic ones which you can add on into that. Next slides. And this is that article. And in that they say more than 20% superficial cells in preputial smear was significantly associated with serum estradiol concentration above 40 pmol per liter. So this also you can add it into that. Next slide. And then coming to the diagnosis, differential diagnosis we have done. CBC, now again, most of these tumors, the Sertoli cell tumors, estrogen producing tumors and all will suppress. They will have anemia, thrombocytopenia, and even leukopenia also will be there because of the bone marrow suppression. And then in histopathology, you can go for the tumor, the Sertoli cell tumor, or the other ones you can take, go for histopathology. And then sometimes you will not be having it, the size will be normal, everything will be normal, but the dogs will have a problem of these alopecia. You can go for blood hormone estimations also. The normal levels as far as estrogen in the females are 10 to 8 picograms per ml, and then in the males 15 to 16 picograms per ml as far as the males are concerned. And then in the testosterone, the normal levels are 1 to 7 nanograms per ml, and then the progesterone, of course, everyone are doing it, 10 to 50 nanograms per ml, and it varies from metaestrus, pregnancy, and estrum, so in that way. The next slide. And then sometimes when you go for these estimations of testosterone and the estrogen, and you will not be seeing excess of it also, but a comparison of the low testosterone and even with the normal estradiol will have the problems, which also can be used as a diagnostic tool. So for that only this paper was done. Next slide. And then coming to the adrenal causes, the least ones, of course, in the adrenal causes, you can see both in the males and females, normally present from the middle age 1 to 5 years. And then adrenal enzyme 21 hydroxylase deficiency only causes these problems. And in this, the excessive adrenal androgen is produced, progesterone is produced more, and more common in Pomeranians. Next. And the diagnosis of adrenal causes. Another thing is the dogs will be neutered, spayed, but when you go for a hormonal estimation, you can see higher levels of the sex hormones. Invariably, that is due to the adrenal level only. And they can be diagnosed using ACTH stimulation test also. To measure these sex hormones using ACTH, you have to go use cortisol at 0.5 international units per kg IV, and then take blood samples pre-injection and 1 hour post-injections. And in that you can see increase in one or more, that is either testosterone or a progesterone or an estrogen levels will be increasing it. When they are increasing it, you can diagnose that this is due to the adrenal one. Of course, the last ultrasonography also, we can find out adrenal tumors. Next slide. The limitations in this, the blood hormone estimations and all, the levels always fluctuate. So when you take a blood sample and then go for a testosterone or any hormone estimation, it varies in the 24 hours. Probably you may have to take 5 to 6 samples and then come to a conclusion, and definitely which is expensive in our Indian conditions. And apart from that, there are numerous estrogenic substances are produced in the body, including the skin also. So their levels also will alter us whenever we go for hormone estimation. And now I said, no, the Sertoli cell tumor produces estrogen, but less than 40% of the Sertoli cell tumors only will be having the estrogen levels. So diagnosing a Sertoli cell tumor with the estrogen estimation, we have these limitations. And then the skin biopsy. The dermatological lesions caused by these sex hormones Even with the biopsy, you cannot come to a conclusive one unless very few of these, the flame bodies, which the pathologist will be remembering it. So apart from that, the skin biopsy will not give us or any clue in as far as sex hormone dermatosis is concerned. And as far as trichogram, we can see, and then even in the skin biopsy also, the non-inflammatory alopecia, that is the one which will be giving us, but again, what it causes, which hormone it causes, we don't get a conclusion from the skin biopsy. And the perivascular dermatitis will be there as far as in hyperestrogenism when you go for histopathology. And then the flame follicles, only the pathologist probably will be knowing it, others may not be know about it. Next slide, sir. As far as the treatment is concerned, the main is neutering only. The neutering is done when the hormones are excess, so we can go for either castration or ovariectomy. And then in estrogen responsive ones, the estrogen responsive, I told you, before they come to the puberty or during the cycles or the pseudo pregnancy, to offset it, you can use estrogen at the dose rate of 0.02 per kg body weight, 0.2 mg per kg body weight. Maximum you can go up to 1 mg of diethyl stilbestrol once a day for 3 weeks on and 1 week off. That is, you go for 3 weeks, leave a gap of 1 week, keep on continuing that till hair grows as far as estrogen responsive dermatosis is concerned. As far as hypoandrogenism is concerned, you can go for 1 mg per kg methyl testosterone. Maximum again you can go up to 30 mg alternate days. But when you go for these methyl testosterone administration, there are chances for the dogs to go for aggression and cholestatic diseases. The liver also will be affected, that we have to monitor them when we are going in for methyl testosterone. And the topical therapy for seborrhea, of course, we all know about it. Okay. The next slides. Prognosis. So as far as estrogen responsive dermatosis, when you go for that hormone, you can expect the regrowth of hairs in 3 months. As far as hyperestrogenism, the regrowth is 3 to 6 months following the gonadectomy. But bone marrow aplasia, in fact, we have to do them before that. Normally, they don't respond, that the prognosis is grave. And then as far as hyperestrogenism, relapse of signs, metastasis, less than 10% is metastasis is possible. When it goes for a metastasis, the prognosis is poor only. So we have to start acting before these things itself. And hypoandrogenism, the testosterone therapy, it is for 1 to 3 months. And in hyperandrogenism, castration, when you go for castration, and you can expect them, the hairs to regrow in 2 to 3 months. Next slides. And the thing is, that's what I wanted to see. Invariably, everyone encounters alopecia or the hair loss. Whenever you see more of these truncal alopecia, and especially the alopecia when it is not there in the head and the extremities, you can think of it. And then, again, I said, whenever the dog comes for a routine examination or for any other thing, as far as the males, when they, after the age of 5 or 6, palpate the testicles, so that also you can see either they can go for a shrinkage or an asymmetrical testicles you can see. Reduction in the size of both the testicles, that is also possible. And then swelling or discomfort in the inguinal or in the abdominal region. Invariably in the cryptorchids after the 5 or 6 years, you can see them when the tumors, when the testicle become tumorized, when they increase in size, they will be popping out of the abdomen, which you can see it also. And as far as, again, the feminization, when the male dog has these feminine characters like gynecomastia, the change in maturation, we have to think of these hormonal problems. Again, the last is bilateral symmetric alopecia. But this is the major sign of these sex hormone dermatosis. Okay. Next slides. And then looking for gonadal disorders, again, you can look for pendulous penis. Normally, invariably, the penis will be parallel to the body. So whenever they have that problem, you can see them, the penis will be perpendicular to the body. You can see them facing the ground. And then the shrinkage of penis, that is also possible. Hemoperitoneum, hematuria. Hematuria will be there when they have problems along with the prostate. You can expect hematuria. And torsion of the spermatic cord, when the testicle increases in size, the torsion of spermatic cord will be there, which will be more painful. And then as far as the female are concerned, sudden swelling of, prolonged swelling of vulva, enlarged mammary glands for a longer period without the showing of the signs, we can think of sex hormone problems. Okay. The next slides. And that's all. Thanks. Just 2 minutes. We will be with the next program with Dr. Jay Prakash.
Just as I depend on and trust my coaches for my exercise and nutritional needs, puppies and dogs can trust Drools Focus. This is because Drools Focus is a specialized dry food that has all the good stuff. Real chicken, whole rice and oats, vitamin C and E, minerals, probiotics. What it doesn't have is wheat, corn, soya, fillers, or any artificial colors and flavors that add unhealthy weight or hamper growth. Focus is especially important for puppies as it contains all the right ingredients essential for growth, muscle building, and immunity. Good for all breeds and sizes, this formula is packed with pure taste and goodness, with more meat and less grain. You see, Focus is all the nutrition attention your little pooch needs, besides, of course, the never-ending physical attention. Drools Focus. Feed real, feed clean.
Watching your little pups grow into big boys is a bittersweet journey. They need love, attention, yes, and focus at all stages. And while they change and evolve, their food needs to evolve too. The Drools Focus range is built exactly for this reason, to give them the best of everything at all ages. For little pups, it's more meat and less grain starter formula. For growing pups, there's a corn and wheat-free formula with real chicken in crunchy kibble. And for our adult dogs, it is a specialized dry food packed with real chicken, vitamins, long grain, rice, oats, and probiotics. Drools, feed real, feed clean.
Sometimes your fully grown dog might insist on sitting on your lap like he's still a little puppy. But he can't be fed what he used to as a pup. Your dog's food needs to evolve as they evolve. And we have just the right food for every stage of their growth. The Drools Focus range has a more meat and less grain starter formula for weaning pups during the period of 3 weeks to 3 months. A corn and wheat-free formula with real chicken and crunchy kibble for the growing puppies. And specialized dry food packed with real chicken, vitamins, long grain rice, oats, and probiotics for our adult dogs. But basically our overgrown puppies. Drools. Feed real, feed clean.
You know, guys, everyone thinks I love myself the most in the world. And you know that's slightly true. But seriously, I love my dogs Fudge and Astro way more. Which is why I give them nothing but the best. And that's why I only feed them yummy Drools. Did you know Drools contains 100% real chicken, chicken liver and eggs with zero byproducts or fillers. And it's packed with all the nutrition my dogs need every single day. Wait, there's more. I did my full homework on Drools, let's see. Drools improves a dog's digestion, immunity and coat. It's great for stronger teeth and bones. It's got kibbles to prevent tartar. There's a vegetarian version and a special recipe for puppies. And, oh, that's it. Yay! Drools Daily Nutrition. Feed real, feed clean. You know,
As a
guys,
parent, it's my topmost priority to make sure that my children are getting the most wholesome nutrition. And that goes for my furry baby too. With Drools, you can be sure that your pets are getting their daily intake of essential nutrients and real ingredients. Made with 100% chicken and eggs, zero fillers and byproducts. Drools Daily Nutrition is every pet parent's go-to. Drools truly meets my main criteria. Real ingredients, and real ingredients. Drools. Feed real, feed clean.
So, anybody, how do you manage feline urethral tract obstruction?
Today, I feel like eating simple home food.
Why
Dal
is,
chawal.
uh,
No. Aryan
they
can't
are,
have that. Just
getting
like
it
Aryan has
frequently.
a different doctor, different routine, and a different lifestyle, he has different
These are
food needs too.
multifactorial
So he
disorders.
can run and play around, digest his food properly, have a lustrous coat,
Under
and not
the
have to go to
stress,
the
you have too many
office.
cat and
Drools
house,
Daily
that sort of
Nutrition is
stress.
packed with real chicken
Even
and
the
egg,
litter box,
and no
whatever they are
byproducts or
providing,
fillers, with minerals,
it should
vitamins,
be,
and
1.5
antioxidants. It's a complete
size,
and balanced
more
diet
than that of
that
the
no
cat.
homemade food
Or
can
double the
provide.
size of the
Give
cat.
your dog the best.
Another
Drools,
thing, you
feed
know,
real, feed clean.
See that, it should be...
Hi guys, meet my love Posh. I fell in love with her in 2014. She was actually a rescue cat. Needless to say, I love Posh a lot and sometimes she loves me, but I don't think that she loves me as much as she loves something else. This is what she loves, Whiskas. Posh loves Whiskas so much that she can literally do anything for it. And do you know that this is the same for every cat out there? Whiskas is #1 cat food in 25 countries. Wow. Cats just love the taste of Whiskas and the delicious range it has. Pata hai? Even I love Whiskas. Not only me, every cat parent I know loves Whiskas because it has all essential nutrients which cats need to be healthy from inside and shiny from the outside. So So bring home the #1 cat food for your #1 and show us what your cat does to get the yummy bowl of Whiskas. Share your entries tagging Whiskas India with #CatsLoveWhiskas and stand a chance to win an amazing Whiskas gift hamper. Hi guys.
Has to improve. And another question I would like to ask you, animal getting recurrent urinary tract infection. So there are several methods of collecting urine for your ABST. You can collect voiding urine, you can collect catheterized urine, you can collect ultrasound type. Which method of urine will be ideal for culture and sensitivity test? While cystosynthesis. Yeah, exactly. See, when you catheterize, there is a possibility of contamination.
होम फूड को बोलो बाय बाय पेडिग्री को करो ट्राई टेक द चैलेंज और तू बन जा स्टार सी द डिफरेंस इन जस्ट 6 weeks यार ऑस्कर से अब ऑस्कर वर्दी रॉकी से अब रॉक स्टार डॉगो बनेगा डॉग स्टार सी द डिफरेंस
Everyday practice. It is very, very important because very nearer to the patient, you can diagnose the problem, you can tell it to the owner. So what you have to do is, our bladder is a mobile organ. It's keep moving. When the urine filled in the bladder, it can go up to cranial part of the abdominal cavity. So what you need to do is, the too much distant bladder, it is easy. Even without ultrasound, you can introduce needle and collect urine. But the size of the needle also matter. Probably you can use 21, 22 gauge needle. You don't use the bigger size needle like 16 gauge, 18 gauge and all. So small size needle for your small animal practice. Even cat, better you go for 24 gauge needle will be ideal. That is a matter. If you use bigger size needle, there are very possibilities of seepage of urine that result in peritonitis and then death of the patients you will encounter. So the technique is, you can also go into Vasava Academy. There is a website available. Some of them you may be linked. There are free webinars available. There's one presentations, half an hour talk about only ultrasound of bladder. So the message is, you'll have to immobilize the bladder. That is very important. While doing cystoscopy, you'll have to immobilize the bladder. Then, if you example, this is the ultrasound probe. There is a reference mark available in all the ultrasound probe. The reference mark is the guidance for introducing the needle. If I am introducing the needle, keep the reference mark here. I want to take cystosynthesis. One hand I am holding the probe, another hand I am holding the needle. So this will give the reference mark on my screen. So always reference mark anterior to the reference mark, 90-degree angle, you introduce the needle so that you can collect urine without hurting. That's very important. Distant bladder is not a problem. But and then how do you, suppose the animal voided the urine, owner brought it for culture and sensitivity test. Anyway, you have to get the urine in the bladder. So what technique you adopt? Any idea? Ready, sir? So, ready? Sir, ready, sir? Ready, yeah? So, next presenter, I need not have to introduce, is the founder of SAPAC, and he is the one man behind all this educational program. And a very interesting software, surgical management, gastric dilatation and valvulus. There is a role of medicine also in that. They are prone to get arrhythmias, how the lignocaine playing an important role. I request Jaiprakash sir to deliver his presentations on surgical management of gastric dilatation and valvulus. Is very, very important, because other case you can take time. This you have to decide on the table. So each and every point is very, very important. You just attend to it. At the end of it, you can have an interaction with him. Please.
Good evening, everybody. Today, not today, this happened 3-4 days back. We were, what we suffered. Coming here, first time in my life, we sailed the boat. We were traveling the boat from my house to the boat. Starting the problem. Here also a little bit of problem. All problem. Okay. Hello. Yes. Sorry. Move பண்ண வருதா? Okay. This is this GDV. GDV become one of the very common. Can you hear? Hello. Yes. The GDV has become very common now. When we compare to 10 years back or 15 years back, we found at least once in 1 or 2 cases in a month we get it. The reason for that is very frank. The feeding habit, what we are feeding now. Feeding habit of the dog. We feed most literature says because of the dog food, different dog foods with more of a carbohydrate, unbalanced dog food, or food with more carbohydrate will cause us a feeding. And moreover, and breeding also plays breeding, the dog breeding, the dog with a large chest animal will have a more prone for these cases. And it is now it become a mandatory to learn about GDV, at least to tackle the situation. Because not like other cases, you can't refer it to other people because you have a very short time of taking care of the dogs. If you lose that time, you will lose the patient. You lose the patient, you lose the client, you lose so many things. Okay, at least to some extent, you should know about the cases and how to take up the cases to save the case, I say. We call that, okay? I will give you some tips and technique so that even people who are in a village, a remote village can take care of the GDV. See, this is sorry. நீங்களே பண்ணிடுறீங்களா? ஒன்றுமே பண்ண மாட்டேங்குது. Everything problem. GDV is okay. The gastric dilatation valves. It's a peri-acute case, not, it's a peri-acute, you know, this is more than acute case. The time you have is only for 6 hours. 6 hours in a peri-acute, very severe case, you have only 6 hours to take care of the cases. In abroad, what they do, they know what is a GDV. The people learn, they know about the GDV. Suppose if they found the symptoms, they immediately call the vets. My dog is, I think, I am suspecting for a GDV or bloat. We want your help. See, before they start their house, from their house, they start calling the people, calling the vet and tell the vet to prepare for that. Vet will prepare for to take care of the GDV. They say, what I want to say, it is a per acute case. Anytime, you have a very minimum time to take care of the case. Okay? This is nothing but twisting of stomach on the mesenteric axis. See why I just mentioned it's a mesenteric axis, because when there is a twisting happens on the mesenteric axis, there is a twisting, not only the organ is twisted, the blood supply to the organ is also get twisted. Okay, it is twisted. So the blood supply, the major compromise in the blood supply happens in the organs which is involved in the GDV. The organs involved in the GDV is stomach. Which organ is attached to the stomach? Spleen. Spleen has got no separate ligament or supporting structure. So the spleen is completely attached to the greater curvature of the stomach. So when the stomach is twisted, the organ is also, the spleen also gets twisted. When there is a twisted, the blood supply to the spleen and spleen is compromised, you will get a splenomegaly, spleen is get spoiled, then you have to go for so many other things, no? So many complications happen. See, sicklement. Reason here, the large deep-chested dog. This is a dog with a deep chested. I'll show you what is a deep chested. Deep chested means chest will be longer, the height of the chest. Depth of the chest will be longer than the width of the chest. Those dogs, like German Shepherd, Great Dane, all those things, Saint Bernard. Actually, there are 86 dogs have a deep chested appearance. These dogs are highly prone for these conditions. Not only previously we thought only the large dog will have that. Not the large dog, any dog, even a medium-sized dog, Cocker Spaniel also has with the deep chested conformation, will have the chance of getting a GDV. And moreover, it is a middle age, even though very rarely it happens in a smaller dog, young dog. Middle-aged dogs are very prone because, see, the stomach loses the supporting system, stomach ligament to the stomach supporting tissue, mesentery. When it gets loosened, weakened over a period of its life, they have the organ tend to rotate. So it is happening in the middle age to the older dogs, mostly middle age to older dogs. See, this is a deep chest. See the deep chest is? So chest is, this is the length. Depth of the chest when compared to is longer when compared to the width of the chest. These are known as siblings. This is chest cavity. Why I am telling? See the stomach, the location of the stomach in the chest cavity is almost the caudal part. A part of the stomach, even though major part of the chest cavity is occupied by the lung and thoracic organs, a part of abdominal organ also involves the chest. That is, one is a liver, part of most of the liver part, and part of the stomach also. So, see, this is what happening. In deep-chested animal, the stomach has got more place to why it is happening in the deep-chested dogs. The reason is stomach has got more space to rotate, to move into the other place. Okay? See, in a deep, say the stomach is, See the stomach position in the stomach again? It has got more place when a gypsy dog that can very well move or rotate on its axis, mesenteric axis, causes a scud. This will not happen mostly will not happen in a barrel-chested or round-chested animals, because the space there is a very confined space. The stomach cannot, even it enlarges, it cannot rotate. This is a reason for deep-chested dog. What is the clinical signs? These are the clinical signs we should well known: restless pacing, non-protective vomiting, retching, and early. This is an early sign. This is why I put it as an underline. Dog which, suppose the dog has a non-protective retching. Retching means it tried to vomit. It will be when restless. It walks there, come here, and started try to vomit, but nothing will come. We call it as a retching. This is go on happening for few minutes, okay, few minutes to an hour. This is actually, you don't find any other symptom of abdominal swelling. Only retching will be there. This is an early symptom. If you take it if you take an X-ray on that, you will find some accumulation of the gas in the stomach. You cannot visually or you cannot palpate the stomach and find out. This is a good place. Suppose the case comes with that, immediately if you take the case, just giving an antacids, any antacid, and make the dog to upside front portion to upside, keep it for some time. This will help to prevent the occurrence of GDV. This is actually GDV. It's an early sign of GDV, where the stomach is slightly distended and tend to rotate. It's not at all rotated. That time you get this sign. So if the dog comes with this sign, it is easy to treat the case by giving antacid. Antacid will go, keep the front limb up, keep it for some time, and make it walk for some time. Okay, you will clear the condition. If you leave it that, if you take that as sign is a simple sign, it will develop into GDV. About 1 hour, even 1 hour, 1.5 hours. Okay, sometimes 2 hours also. Retching. Some people come with retching. If it is very near to that, they say that vomiting, try to vomit so many times it couldn't come. This is actually the owner, they neglect. They're just vomiting, just to try to vomit, nothing has come. So that is prolonging for some time. If it comes occasionally, then it is easy for us to treat. Talism, salivation, abdomen. Then abdomen is get distended. Okay. Then wooden horse position. Once they get distended, dog will be in a wooden horse. It won't start, won't move. Weak collapse, all those things. Dog, you cannot expect GDV. Sometimes I have seen a GDV with no symptom of bloated. But we took an X-ray, they found GDV. Took an X-ray, we found there is a torsion of things. So you will see the GDV in a different range of symptoms will be there, from milder form to the acute form. The milder form will ultimately end up the acute form within a short period of time. Okay? So it will come with, say, if it comes with, the dog comes with, say, I mentioned here, it comes with the wagging tail. Some dogs comes with the collapse stage, they will bring it in with a recommend stage. So the symptoms will vary from normal, near normal to the, even sometimes it will come with the very, this is, you should know, the diagnosis here. Now I'll tell you what are these are the symptoms you will get. Not, you don't expect the dog, we should come with the serious conditions also. This is a risk factor, I told you, large breed, deep chested, increasing age, familial history. Familial history is, I've seen a breeder, a gradient breeder in Chennai. He's very great. His dog is cost him, he sell it for 1 lakh, gradient 1 lakh. But we have found every time he will come into the problem. every time, not only his breeding, his dogs, wherever is, at least once in his life, the dog comes with a case of GDV, in spite of so many. So what I would want to say, familial history is also a major. Suppose if you say a dog has got a GDV, don't get the puppy out of them or don't breed them, because they say breed. This is also familial, genetically can related to this. And episode of just gastric dilatation. Sometimes it comes to gastric dilatation, that will definitely 90% of the dog end up with a GDV. So better you can advise them for a preventive measures like a gastropexy. Okay? If you can take the GDV, just dilatation, you can treat it with the antacid, put something, orally, it will become okay. When you can see that, I'll show you the X-ray how it look. So it will become all right. But you should tell the owner, this will definitely going for a GDV in future. Okay? And then advise them to go for a gastropexy. It's a procedure. It's a simple procedure. I'll tell you also. History of splenectomy. Splenectomy also, sometimes you will be doing splenectomy, you will expect a GDV. That time also you will go for a preventive measures. Large, see, this is a very, very important. Some people, they say, I'll feed my dog once a day. I'll feed so much, he will eat, that's all. Those dog, if it is a deep-chested, definitely you will get that patient to your practice back. You should tell them, deep-chested, it's a mandatory, it is a duty for a vet to tell the owner, if they have a deep-chested dog, like what I told you, tell them to feed at least 2 times a day, minimum. I'll always advise them to go for a 3 times feeding. 3 times feeding, smaller portion, divide into 3 times portion. That will, you can save the dog throughout without GDV. Otherwise, he will get 1 time feeding. Dog will definitely get a GDV early in his life. See, this is a picture. First stomach, normal stomach, how the duodenum, gas expand. Then see this portion of, I think it's no. Point. Always, when the stomach is rotated, see the duodenum on the left side, right side. Once it's expanded, it goes to the right side, dorsal side, occupies on the left side. The fundic portion of the stomach goes to the left side. I'll show you the different the one. See, this is what happened. 4 stages. Normal portion. Normal portion, see the pylorus goes up. Why I am telling this, suppose if you want, once you open, you want to, repositioning of the stomach is mandatory, okay? This is one surgical position. Surgery, you will do the reposition. Open, the first thing is reposition and examination, and then I'll tell you what are the surgical steps. In reposition, you should know where the pyloric should be there. How to reposition? The stomach is rotated. You should reposition the stomach. So this picture will guide you. Pyloric, see, goes there. Pyloric occupy this position. See, this area is the area. This is actually greater curvature of the fundic portion. Okay, dorsal greater curvature of the fundic portion. Occupied, he just came to that level of left side, right side, lower end. So because of the rotation, you say that area become black in color because of what? Blood supply. Reduced blood supply and end up with the necrosis. This is, see, quick, I'm telling you. This is a position, normal position. The pyloric on the right side came to this left side, and the duodenum is trapped in between the esophagus and the fundic portion. Okay? This. See, this is a blood supply. Where is the spleen is located here? Spleen is on the right. You see, this is the spleen. This portion, when it rotates, these are the portions. This is highly vulnerable for necrosis. Usually, when you are going for if you delayed case, that portion is get necrosed, then you need to do a surgery known as what? Partial gastrectomy. Gastrectomy you should do. These are the procedures, surgical procedure you will be expecting when you are opening the stomach. Okay? See the spleen, how the spleen position will be there. This is a different 90 degree how it is, 180 degree, 270. It rotates to a level of 360 degree. Okay? Each degree, you see the spleen position on the stomach. Now I'll go to pathophysiology. Nothing but I already explained. Decreased venous return to the heart, okay, because of distended stomach, very severely distended stomach, started pressing the vena cava. So the blood supply from the lower vena cava return to the heart will completely stopped. I can say stopped or stagnated. So because of that, you get return to the heart. Heart won't get return, blood won't be there. Okay, you will get hypovolemia, systemic hypertension, myocardial injury because the blood is not there. Myocardial injury, shock, gastric ischemia, splenic torsion, all those things I explained. Okay, these are the sequence of pathophysiology happening in a GDV. There's a small, just a gas in the stomach, end up with a lot of complications in the animal. This is what we should keep it in your mind to treat when you're taking the cases. You have to target on all those things to save the animal. Abnormal. Now we are coming to how to diagnose. This is very, very important. If you have an X-ray, is must. You should have an X-ray. When you are keeping the X-ray, when you are keeping the patients on the table, usually I'll prefer keep the table patients on the left side. Always I'll prefer the animal will be on the left lateral position. Okay? Left side is on the table. But for this cases, GDV, if you are suspecting GDV, the right should be on the table, right lateral position. The reason for that, because any organ which is very near to the table will be visualized very clearly on the X-ray. Okay? Any organ of the abdomen which is very near to the X-ray film will be visualized very clearly on the X-ray film when you take the X-ray. So what happened? Now our motive is to find out where is the location of the pylorix, because pylorix is migrating from the left side to right side and the lower end to the ventral to the dorsal. So we should know where is a pylorix to find out whether it is a GD, just GDV, or just GD or GDV. Okay? So that is one reason for that. The other reason, stomach is also, the fundus is already enlarged on the left side. So pressure on the left side will make more discomfort to the animal. Make the animal on this thing and see the sign of compartmentalization. I'll show you what is that. Suppose if you want to take another picture, you need an orthogonal picture after treating, or if you want to take a 90 degree later, you need to go for dorsoventral, not the ventrodorsal. Ventrodorsal you put, animal will be already stressed in condition, it will end up with a more problem. See what is this? This is just GD. See this, the stomach is just extended. Can you see any other part of this? The stomach and the pyloric part, everything in a round mass of black shadow. Okay, round mass of black shadow. Which this is indicated of, if you get this kind of X-ray, we are happy. We are we should be happy because it's easily treatable with antacids or with a gas. No gastric tube, you can just insert, take it away, you can release, you will be happy. But you should inform the owner, this fellow is a prone case for GDB in future. So we should plan for other preventive surgery like a gastropexy in future. You can very well treat the case, send it out. Okay? See here you see. See, this is a fundex. What about this? You see that the other portion, there is a division between the two portions. The round portion is divided by two portions. One is upper part, the lower, ventral to the is a lower part. This is a fundus. The upper part is a pyloric. So the pyloric portion will be always where it should be. It should be on the ventral side of the abdomen. Now it is transferred to the dorsal side of the abdomen. And you see there is a compartment, there is a white mark between this and that. Then two compartments are there. The smaller compartment and the larger compartment of black hairs, black part, the small compartment of mixed of black and white, and in between white mark. This divides the two parts. This is actually due to the torsion of the pyloric antrum. When there is a pyloric antrum twisted, the soft tissue on the pyloric antrum, okay, it makes this a compartmentalization picture. Okay, you will see visualization of this. See the other picture. Now you can see very well appreciate the upper part. See, pylorix has gone there, stomach is here. Okay, so this is a clear case of GDV more than 180 degree. Okay, this is now we have to plan for the other part. This one by inserting at stomach won't be helpful. We have to plan for our surgical procedure. See here, this is a dorsoventral position where the pyloric should be on the other side, right side. Pyloric has gone to left side also. Both the pyloric and stomach is on left side. But in severe case, you don't find this whole thing will be black in color. Now it's a partly distended stomach. This is partly distended, partly displaced stomach. So you find it's, in fact, some of the where we have removed some of the air, we found the pyloric is still in the same position. Now see, what is the difference between this and this? What do you see what difference you see from here? Which one? சொல்லுங்க. இது பிளாக்கா இருக்கு ரொம்ப. அப்படியா? இல்லையா? See, both are GDV. Both are GDV, okay? Because you see the pyloric on the upper portion. Here is also pyloric on the upper portion. Both is, you can see the compartmentalization. So two part up there. This is also two part is this. What is the difference between this? No, this is one side. You can't take. I always take in the right lateral. Okay? What do you get that? If I get this type of X-ray, I'm very happy. I'll be very happy if I get this type of X-ray. If I get that type of X-ray, I'll be a little sad because I have to work too much to save the animal. Why? No, twisting is more or less make me. Huh? Correct. It's a matter inside. Or the content inside. The content inside is only air. Okay? Mostly air. What I can say, mostly air. The content here is a less air, more of food particles. You see the white little bit of air, but here I cannot see here, I can very well save the animal by try to put a tube inside, take it away, or I can truckerize the gas, okay, remove the gas and then put a tube and remove it. So without surgery, some of the cases will come out with this. Without the surgical opening, I can very well handle it with only with the truckerization, truckerizing the stomach, removing the gas, and once you remove the gas, the stomach will become smaller and little taut. You can put a gas, try to remove it with a suction tube outside. Without that, I can do it at that moment. Okay, I can stabilize the patient for that moment and then plan for a gastropexy later. But this I find, if I find this, I won't try this. Because trying is nothing. If you put a trucker, you will get a small peep of gas, that's all. Then you immediately trying all those things, putting a tube inside, won't work at all. You will be waste of time. You will be wasting the time. So this small X-ray difference will be helpful for you. Immediately you can plan for your surgery. Okay? Stabilization, surgery. So next plan. Then lab test. What I do, say lab test also to some extent you can't wait to do you can't send the blood to the lab and wait for its result because you have no time. You have only a few hours to save the animal. Once even every minute is counted, okay, you will find lot of complications there. See, these are the things you can say. You will find a bun elevation, creatinine elevation, bun elevation due to secondary hypo. It's not due to a kidney at that stage. And you can see, I'd say CK, creatine kinase level, this damage to the muscle because the blood supply to the lower end is everything. No, it's just a compromise. Every system is in a compromise stage. So all the system will get its action on that. You will see all reflection on this. Here, CBC and electrolyte will be very useful. You need to do useful to analyze the status of the shock. Okay, status of the shock, whether it's a hypovolemic, how much it is, what is a PCV. Then to see the effect of your fluid therapy, you need to do the CBC and electrolyte intermittently and find out your effectiveness of the and hyperlactate. The serum lactate is a very good. It's a marker, I can say. It's a marker. If it is a very high, more than 6 millimoles, then you can expect there is a major damage has happened. And the outcome of the surgery will be question mark. The prognosis you can tell them it is a grave. If a lactate level is very high, hyperlactate, lactemia is very, because that indicates there is a severe necrosis of the organ. What organ here? Stomach. So this will end up with hyperlactemia. Lactatemia is one of the marker to find out thing. And also it is one of the marker, it is a lesser thing, marker to find out whether the animal is stabilized properly. If it is a level is gone down to little normal, then say we are giving a treatment, pre-surgical treatment of fluid therapy is a good way. Then that gives you a very good prognosis. It is going to be a good case of GDV. Okay. Then what is a pre-operative treatment? This is very important. You need to fluid. Because animal is all what? It is highly in shock condition. No blood is coming because of compression on the vena cava. Heart is also started, it's a compromise working. So you need to give them fluid to a level. First stabilization is a first major most thing for the GDV. See here, then stabilization, you have decompression, you can do it, I told you, gastric tube, and the percutaneous localization. I'll show you the thing. See, first treatment priority. What is my treatment priority? It's only correction of hypovolemia, not the correction of gas. My first priority, correction of the hypovolemia. I will give the fluid. Rapid fluid treatment is very, very important. You should, where to, see I mentioned it here, only jugular and cephalic vein. Why? Why can't you give in the saphenous? Huh? Caudal vena cava is compressed. Whatever the fluid you give, it won't go into the system. Systemically, it won't go into the heart alone, heart itself. Okay? So you should select only the peripheral, anterior portions like a jugular or cephalic veins. Better you put, I always put two veins, not one time. I put on two legs. Okay, give a fluid, very rapid fluid on both sides. Okay, you can give a ringer lactate or saline, depends on the sodium and electrolyte balance. Electrolyte is very, sodium is less, you can give a sodium chloride. You can, ringer lactate will be better. Even, okay? Catheter. Then I'll see the crystalloid solution, a rate of, see the rate, 60 ml per kg per hour. Say 90 ml per kg per hour. Okay? So much of fluid has to pump into the system to counteract the shock. Okay? Colloidal can be tried. Sometimes if it is a very severe shock, this hypertonic solution. Hypertonic, sodium chloride 7% solution with the dextrose 570 ml will be useful in counteracting very severe case of shock. How to effectiveness, you know, fluid therapy is okay. By clinically, you can see the mentation, heart rate will increase, all those things, capillary filtering. Clinically, you can assess the effectiveness of your fluid therapy. Then, therapeutic management, these are the IV fluid I told you. Analgesia, you should always use pure mu agonist opioids. Pure mu, don't use any other non-steroidal anti-inflammatory is not indicated. The painkiller analgesia only with the opioid, fentanyl. If you're able to get fentanyl, is very good. Okay, IV injection of fentanyl, or at least you can go for the buprenorphine. Butorphanol and buprenorphine will be to some extent is okay. Buprenorphine is good for taking care of the pain. Butorphanol for taking care of the anxiety. See, you can start with the butorphanol, okay, butorphanol, and do the simple procedure like intubation. Everything can be done with butorphanol. When you are going for a surgery, then you can follow with the buprenorphine. Because that buprenorphine will have a more analgesic effect than the butorphanol. Okay. Antibiotic, broad spectrum. Anti-arrhythmia is if needed. I told you if needed, because it is not premature ventricular contraction is very common, but it get itself corrected. If it is a very severe case, then you have to go for this. I think I should go for. See, first I told you gastric stent compression, sedate with fentanyl, stomach tube, measure from incisor to the rib, last rib, lubricate, gently manipulate. You just gently, you don't put it like that. Make the animal like this, not on the lateral side. You should be like a sitting position with a little bit of sedation, lubricate, and slightly what? Once it reaches the esophageal sphincter, it is little hard to push it inside. Okay? If you push it very hardly, you may end up with the rupture of the case. What you need to do? Slowly on that position, you should. See, you should counterclass. counterclock movement of the tube will enable to reach the stomach. Don't push it like that. It's end up with a rupture. Okay. After the stomach, this is you can do when there is a compression. If you are not reaching this, you can't achieve any movement after that. Don't try. You take it out, because it shows that it's a completely the gastroesophageal sphincter is completely twisted. Then no point in removing. Maybe you can try after removing the gas. After removing something, you can try once again, not with the gas or removing something. See, this is what you are measuring. Then see, this is a way. This is a way. Now, this is actually to put a gastric, to prevent the tube to. This is a simple method you can use to prevent the dog to bite the stomach tube. But if you put a little, I told you, fentanyl or butyrophenol will be better with the diazepam. It will hold good for the endotracheal, the stomach tube to twist. Butyrophenol with the diazepam. Both together will definitely helpful. That's sufficient for the stomach tube. Then, if you are not relieving, if you are not reaching, you are not achieving that, then you have to go for percutaneous gastroenterostomy. Mostly try with the right side, on right side, on posterior to the last costal thing. Here, what you have to do, you have to percate. This is more important, because normally stomach will be anterior cranially placed, spleen will be caudally placed. When there is a twisting, what happens? Spleen also twisted, it occupies a different position actually. Actually, it is in the left, it actually we call it cranio-dorsal position. Cranio-dorsal position on right side of the stomach, spleen will be there after twisting. So, you need to do the percussion. At the other side, percussion of the area should be revealed tympani. If you feel the tympani, that is a place to put a trocar or a high bore needle. If no tympani is percussed, that shows spleen is over that area. So avoid that area, try on the other side. Make it on the left side and do it. My main thing, there should be tympanic feeling, percussion should be there before you put this. This is a. See, general anesthesia, pre-medication, I already told you, opiate with benzodiazepine. Usually propofol is ideal. Use minimum amount of propofol. Don't use a normal dose of 5 mg to 6 mg per kg we use. Better try to reduce it. Maybe 2 mg is sufficient. Reduce the minimum amount of propofol for this, for the induction. Maybe because that other opioid will be helpful for this. Then you go for isoflurane, gas anesthesia. This is gas. We have, I think, video was there. Video is not working. You take it. If you have this, it's working. Super. Every work on something. See this is in cases in respiratory compromised patient. Okay, you can use this if you have a ventilator. Anesthetic ventilation is very useful. Useful. You can ventilate till the dog it will help it. In fact, pushing the oxygen inside, more of oxygen will go into the tut, and easy for the anesthesia to maintain also. Say surgery, our surgery is 3 goals. One is repositioning first. The abnormally positioned stomach. I told you, pyloric vent will be what? Pyloric is on the left side on the dorsal position. Fundic on the right side on the ventral position. First, after opening, you have to push the fundic to the dorsal position and pull the pyloric to the ventral portion on the left side. So on the right side, it will be a left side. Simultaneously, you should push from the right to the dorsal side, fundic on one hand, and the other hand, you have to push the fundic from the dorsal side of the left side to the ventral side. This is where sometimes you will be doing it differently. You will be making what? More damage, more problem. You will be pushing, then it won't reposition, and you'll end up with a problem. See, this is why the clockwise, typically clockwise will occur. Fundus should be pushed dorsally, while pulling the pylori, this is a position, okay? Then the second thing, after repositioning, you have to critically evaluate the whole area. That's why we have to put the longer incision, laparoscopy incisions, to critically evaluate the other organ, especially the spleen and the different part of the stomach. Okay. Then after that, you can do the partial gastrectomy if there is a gastric necrosis, or splenectomy if the spleen is damaged, and do everything. Perform right side gastropexy. Okay. I think see the position, how the length of a laparotomy position. This is a length you should have after you need to do that. Don't stop it up. See, here, this is a small point to be taken care. Even if you open from this, okay, you cannot push it back. See, pushing and pulling, reposition can be done only when the gas in the stomach goes down, okay, or the food in the stomach goes down. If the gas in the stomach goes down, it's easy. Even trocar will do, or with the trocarization, we can remove easily. You can remove this one. I told you the other part, you have food in the stomach. Your food is full of food in the stomach, require first to remove the food content outside, then only you should go for target for venture for the reposition. Then you cannot do it. You cannot do anything. Even do 3 people to pull, you can't reach that. What I always do, I'll put a small incision, not incision, half the way, and cover this part. Okay. See, put a first suture, because it's very tough. Even if you open, it won't come out, because it's very torturous, no, very highly tension thing. It won't come out. Remove it. See, you have to remove. Put a saline, remove. Okay. This is as you remove, the stomach try to pull inside. It goes inside. You have to you cannot leave it inside, no? Then see the part of this is a gastric necrosis portion. It's a very bad case. Then you need to go for a gastrectomy. See the spleen. Spleen is torsion, spleen color is also damaged. You need to go for a splenectomy. See, where splenectomy, I told you, this is how the spleen takes place. These are the artery you have to put. You can take a picture. First you need to, these are the artery you have to ligate before you remove the spleen. That's a different entity. See, partial gastrectomy we have done. See, see, I just want to show the partial gastrectomy site. How far you have to remove. The incision site should bleed. Okay, that is a point where you should stop the resection. The bleeding, the incision site, the partial incised site should be bleed. That is see, the bleeding is there. You can see the bleeding. You should reach that level. Okay, I'll finish 5 minutes, I'll take her. Okay, bleed. See, I'm putting a two suture line. One is a continuous sutures to involve only the mucosite. Okay. See this. Then otherwise, the cornwall you can put or these are gastropexy method fixing. This is nothing but, say, put an incision on the lateral abdominal wall near this and take a loop here like this, insert to that, bring it to the same position and fix it. This is a belt loop gastropexy. Okay? You can see that now I put a incision like a belt. I created a belt on the abdominal wall and created a loop on the pyloric random and inserting it, placing it in the same thing. This is a very simple. This is also a little bit more. I always do this incisional gastropexy. It's very simple and more or less effective also. They say, literature says, belt loop gastropexy will gives you 80%. This will give you 75%. This one 5%. No, there's no way. But it's very simple. Easily you can perform. Say you are putting incision on the abdominal wall. Okay. Here also incision. What we are doing? This part. Here incision. You are this and this. You are putting a continuous suture. Okay. Then after that, this part and this part, you are putting a continuous suture. This will have a very good addition. It's very easy. One incision on the abdominal wall, okay, and one incision on the cerebromuscular layer of the pyloric antrum. You can put vertically or horizontally the same way, same direction. You put on the same thing and do it. Okay, within 10 minutes, if you are very happy, if you are expert, 10 minutes. Amateur, 15 minutes. Okay. So, see, incision on the abdominal wall. All. You have to give it 20 minutes for this extra. See. See, incision on the, see, incision on this. See, that's additions. Incision. See, finally, you will get this kind of additions on this. This is a pexy. This is what I say, incisional gastropexy. You try this, it's very simple. Even for, I told you, as a prophylactic, you can do it. You can suppose if the dog has got with the GDB, you are going to GD, you can try for this. Or while doing other surgery, you can do this. You can tell the owner, I am doing this kind of spaying, can I do this? Because if it is a deep chested, you can take one more money more charge for this. Post-operative care, I think more of, Okay, I will finish this. I don't know what. Very sorry. Okay. Any question? You will ask me later. Time is already down. Thank you. Thank you very much.
Thank you, Professor JP, sir. Now, in fact, the president only designed all the lectures for 45 minutes duration. That was the reason. Probably in future, if we select a bigger topic, we will allot more time so that all you can listen to him. And now, almost we have come to the end of our today's program. And now I'm going to call upon the sponsors. Without their support and their finance, these type of programs are nowadays not possible. So I request you all to sit here itself, listen them, and give them their due credit. Please, I request all to sit here. And we have 3 to 4 sponsors time. In the meantime, we have some felicitations programs also, and we have some announcements also. Please wait. First, I request Boringa to give their lecture.
Hello. Good evening, everyone. So nice to greet you all on this exotic location. Thank you so much to SAPAC Association for their dedication to continuing the medical education programs and giving us this platform to talk about our products also a little bit. So thank you, everyone, for attending and giving the attention. I will not take much of time. I will be brief. I know it has been a long day and we are antsy. So just talking about the company that I come from, it is Boehringer Ingelheim. I'm sure as the players in the vet industry for a long, long time, you know about the organization. So just a brief about our organization. This is a family-owned business which was founded in 1885. So quite a history and heritage that we have here at Boehringer Ingelheim. Also, it is one of the companies where we are employing more than 50,000 employees all over the world. We are present in more than 176 countries. There is a strong dedication in the organization towards R&D as well, which reflects in our investment towards R&D, which goes up to 1 billion every year. So, a unique thing about Boehringer Ingelheim is that we are one of the rare organizations where the human pharma and the animal health work hand in hand. Our objective at the organization is more focused on One Health, and towards that goal we are working by simultaneously focusing both on human and animal products. So some of the products here you can see overall around 20% of our business is accounted by animal health portfolio, and our biggest brands, if you see here, NexGuard, Frontline, they are the companion animal brands, especially NexGuard, which is a $1 billion brand for us worldwide, and it is being present in 156 countries in the world. So coming to the BI Pets portfolio in India, our portfolio in India is ever growing. We are always working towards fortification of our portfolio and adding more and more products. Currently, we are present in two major segments. One is Pet Para, where we are present with NexGuard, Frontline, and Broadline. And also, in last 1 year, we have launched the complete range of core and non-core vaccines with our Recombitech range, and Rabicin, which is a very well-known brand as far as ARV vaccination is concerned. So, like I said, NexGuard is the world's leading tick and flea solution. So this is an oral that we are having in soft chew tablets. Afoxolaner is the active ingredient in NexGuard. The product is present in 4 weight categories, starting from 2 kgs to 50 kgs. Some of the benefits of the product. So this is the only product which is available as a monthly therapy and also in a weight range starting from 2 kgs and as early as 8 weeks of age. So especially in the rapidly growing pups where the weight changes from month to month, you can easily switch the patient from one weight category to another. Yeah. Another advantage of the product is that this tablet can be given with or without food. So the tablet is a soft chew. It is available in a beef flavor, but the source of the product is soy protein. So it is actually a vegetarian product with a flavoring which is appealing to the pets. So the palatability goes much higher and the patient compliance also improves dramatically. And as I said, this is the only ectoparasite therapy which is available for growing pups and very helpful in young pups who come to your clinic or the small breeds which are there. Below the 10 kg weight also you can use the product safely. Coming to Recombitech, which is our recently launched vaccine range in India. So this is the only recombinant vaccine in the canine segment that we are offering. Mostly you have the traditional MLV vaccines, but for the distemper virus, we are giving the recombinant technology, which I will talk about in my next slide. But we also give, a 15-month of duration of immunity for Cryptotyphosa, and also our MLV for parvovirus covers all the field variants, CPV CPV 2A, B, and C. So let me just talk briefly about the technology which is there in Recombitech distemper. So here what we do, instead of using the whole virus like you do in a traditional MLV, from the distemper virus we extract only the HF and A proteins which are responsible for the immunogenic response. We then put this protein in a canary pox vector which is big in size and carries the DNA information well. This canary pox vector is then used in the manufacturing of our distemper vaccine. So once that vaccine is given, as the virus tries to multiply, the canary pox vector tries to multiply. So this is an avian virus. It cannot multiply in the canines, but during the process, the HF and A proteins also multiply, which in turn gives the cell-mediated and the humoral immune response in the canine. So this is a distinguished technology that we are using. The advantage here is that in the presence of maternal antibody, the challenge that is present for the distemper virus is very well taken care of. So there is a study which I will just talk about briefly here. In one of the studies done for the annual booster with the recombinant distemper virus vaccine that we are having, there was a 4-fold increase 7 and 14 days post-vac in 90% of the patient, while with the traditional MLVs, it was found only in 10 to 35% of the patients. Yeah. Lastly, I will just take a minute, as I have been reminded that I have only a minute to talk about Broadline. Yeah. So Broadline is the spot-on. This is again a dedicated product that we have for our feline category. The combination here offers the broadest spectrum coverage for internal as well as external parasite with a spot-on in cats. So this is a product which can be used for all kind of deworming as well as control of ectoparasites in cats. Lastly, there is a short video that I would like to leave you all with. Thank you so much for your time and giving attention. Thank you. Can you play the last slide, please?
We are passionate about the human and animal bond. We are independent. We value our heritage.
Next, right for pass.
Good evening, everyone. Myself, Dr. Sachin. So, I'm thrilled to introduce you to the next generation of pet food. So, as you're all already aware that Right for Paws has introduced minimally processed food in India. minimally processed food is the next generation of pet food, which is globally registering highest number of increased growth and adoption rate. And minimally processed food is a preserved food which essentially preserves the natural ingredient in the raw form without modifying its molecular structure. Okay. So why minimally processed food? One should be having a question, and why one should shift to the minimally processed food. We look into a spectrum of dog food. We see in one end of the spectrum, there's a raw food with the positives of natural nutrition, is retained and higher bioavailability and biologically appropriate. But it also carries its own negatives, like there is a potential contamination with the microbes, and there's challenges associated with the storage and handling, and challenges associated with nutrition balancing. And when we see the other end of the spectrum, we have a processed food. So this processed food, as you're all aware, it's convenient to use and storage and feed, and also has the long shelf life. But its drawbacks outweighs its positives. That means the high heat and pressure which is used in the processing techniques, which leads to formation of reaction products like advanced glycation end products. These AGEs will create a high risk for the inflammation and lifestyle diseases like IBD, skin issues, and obesity. And also due to the high temperature, there will be a reduction in the bioavailability of the nutrients. So when you look into the minimally processed food, so this is a preserved food which preserves the natural nutrients of the raw ingredients without modifying its molecular structure, and also it combines positives from the both sides, that is the natural nutrition from the raw food and the whatever the convenience of use from the processed food. So that's why we call it as a next generation food. Can you change the slide? Yeah. So Right for Paws is also contributing to the global research through its partnership with the Dog Risk. The Dog Risk is a group of research group from the University of Helsinki, from Finland, which carry out the independent research on association between dog nutrition, health, and diseases. It is one of the largest program in the world with over 20,000 dogs currently under it. And I think Right for Paws is the only company from India which is in partnership with the Dog Risk. So after a brief about the, I wanted to give about the brief introduction about the study that we are a part of. About 20 dogs were put under the Right for Paws diet over a period of 24 months. That's more than 2 years. And the periodic recording of the health parameters is done by an independent veterinarian. And the blood samples analysis is also done by an independent laboratory. And these reports were sent to the Dog Risk for the further analysis. Currently, these reports are under the peer review. It will be published in 2024 by Dog Risk. The parameters that were captured for the study were broadly classified under 3 umbrellas. In each, there will be 15 to 17 attributes, like in physical characteristics like body weight, body condition scoring, and hematological characteristics like complete blood count, and biochemical parameters like total protein, LFT and KFT. So what we observed was the results are very encouraging. Even after subjecting to 24 months instead of 26 weeks, that is 4 times more. These 26 weeks read by the guidelines. The dogs have shown very good health parameters and also the results were in the normal range. And here are some of the research based on like why one should shift to the minimally processed food or natural food. Like when the dog is given the natural food, that increases the skin microbiome and this microbiome diversity. This skin microbiome diversity is directly related to the skin health and coat. And also, when there is a ultra processing, there will be a formation of AGEs. This increases the chances of obesity and IBD. And the dog which was exposed to the raw or natural food in the puppy has shown reduced incidence of the allergic or atopic skin conditions in the adult food when compared to the dog which is given the processed food. So even we have so many research on this. We can share for the references. So and coming to the nutrient losses about the pet food types. So here can clearly see that when we compare the processed food and minimally processed food, the nutrient loss in the processed food is the highest, whereas the nutrient loss in the minimally processed food is the least. So these are some of the reasons why in the processed food there is a requirement of, even after giving the food, there is a requirement of lots of supplements. So just to give you a better picture, this is the nutrient loss, specifically vitamin loss. Vitamin E, vitamin B2 and vitamin A, there is a more than three times the loss in processed food when compared to the minimally processed food. And we have taken an accelerated shelf life test for the right for paws for over 18 months. And even we have observed that there was a minimal degradation is observed in the accelerated testing. This is because of the benefits of superior packaging and preserving technique. So even in the micronutrients also, we have seen very minimal degradation. So this is the first forum where we are speaking about the study that we are a part of. We'll be sharing the final report once it is published by the Dog Risk. So we are requesting you to review and adopt it in a practice based on its merits. Thank you.
It's time to felicitate our speakers. I call upon Dr. Ilana Water to the stage, for whom Dr. Uma Maheshwari, our Joint Secretary, will honor. Call upon Dr. S. Tilagar, sir. He will be honored by our General Secretary, JP, sir. Yes, sir.
Everybody, you know, Sir Dr. Tilagar, sir, our former Vice Chancellor of Tanvas. He is also a member of the Dog Risk Committee. He is also a member of the Dog Risk Committee. He is also a member of the Dog Risk Committee. He is also a member of the Dog Risk Committee. He is also a member of the Dog Risk Committee. He is also a member of the Dog Risk Committee. He is also a member of the Dog Risk Committee. He is also a member of the Dog Risk Committee. He is also a member of the Dog Risk Committee. He is also a member of the Dog Risk Committee. He is also a member of the Dog Risk Committee. He is also a member of the Dog Risk Committee. He is also a member of the Dog Risk Committee. He is also a member of the Dog Risk Committee. He is also a member of the Dog Risk Committee. He is also a member of the Dog Risk Committee. He is also a member of the Dog Risk Committee. He He's going to give us a enlightening lecture tomorrow, and we are the SAPAC proud to honor Dr. S. Tilagar, PhD, former Vice Chancellor to Anvas, for his sustained dedication and plentiful service for the upliftment of veterinary profession in India. And we are honored.
I call upon our President Venkatesh to honor JP sir. Sir. I call upon our Vice President, Dr. Venkateshwaran sir, to honor Venkatesh sir. I call upon Dr. S. Sendil Kumar, Vice President, to honor Venkateshwaran sir. Yes, sir. Sir, அப்படி நின்றீங்க. Next, I call upon Dr. M. Chandrasekhar sir. Sir, நீங்க அப்படியே அடுத்து I call upon our treasurer, Dr. Suresh, to honor Mohan Kumar sir. Please come in. Next, we call upon Zotis to present their presentation. Neon. Huh? Yes. I call upon Dr. Vairavaswamy, EC member, to honor Dr. P. Sridevi ma'am.
Hi, good evening, everyone. So, I'll just give you a brief about the presentation. I will not take a lot of time. So, I am Dr. Pratik, and I'm representing Zoetis India. So, before I start, I would like to walk you through just a small video. Then I can talk more about the product. It's gone again. All right, so we are back.
Congratulations! You're on your way to offering clients a more convenient way to give dogs the protection they deserve. Created by Zoetis, Simparica Trio is the first and only parasite preventative to provide triple protection, combining seralaner, moxidectin, and pyrantel in a single chewable, easily given to dogs once a month.
Yes, just to reiterate certain points. So Simparica Trio is the first isox combination molecule introduced in India, which gives three different propositions. First is the comprehensive protection. Second is a single product can do a job of 2 or 3 products. And third, it is very easy to give. It can be started, it's a palatable tablet. It can be started from a very young age. The 3 different molecules give a 3 different layer of protection. So seraliner, as you know from Simparica, it gives you protection about the external parasite. Moxidectin gives you protection against nematodal infections, and pyrantel for intestinal parasites. So these 3 molecules make up a 3 different unique proposition for your practice. This is the label claim for India. So as I said, it can be started very young age, from 8 weeks of age and as low as 1.2 kg body weight. It can be used for treat and control of ticks. It can be used for treat and control of fleas and the whole life cycle. Treat and control of the intestinal parasites, and for the nematode, vascular nematode like your heartworms and lungworm. And just another video to brief you about the second product. Yes, just wanted to introduce a new addition in Zoetis companion portfolio, our vet scan portfolio. We have the hematology analyzer HM5, the biochemistry analyzer the VS2, Fuse is the connected device, and the urinary analyzer.
Now I request Dr. B. Nagarajan to come to the stage. He will be felicitated by Professor M. Chandrasekhar. Now the last sponsor session by Royal Canin. It will be over in another 10 minutes. After that, the cocktails will be served here and then the dinner in the restaurant. Please wait for another 10 minutes. Yeah, Royal Canin, please.
Check. Thank you. A very good evening and a warm welcome on this wintry, rainy Ooty, beautiful location. I'll be quick. My name is Ravikant Upadrasta, and I'm the vet marketing manager with Royal Canin. And I represent a company which started more than 50 years back. Very few companies actually get to say that. And it's a company that was started by a veterinary doctor in France. Without further ado, I would like to introduce the speaker for the evening from Royal Canin. More than me, I think everyone present in the hall know him, is Dr. Balaguru. Dr. Balaguru, over to you.
Thank you very much. Thank you, Ravi. Once again, good evening, one and all. I think I'm right now standing between the dinner and the party and the beautiful Ooty. Of course, I will not take too much of your time. Thanks for your attention. Yes, of course, Royal Canin started in the year 1968. We have been more than 50 years in this industry. And Royal Canin is known for the innovation, known for its innovation. Every now and then, there is a challenge, there is a disease which emerges. That is where Royal Canin pitches in and creates or develops a new product. And today I'm going to talk about a new product which is there in the market, which is called which is for the management of canine atopic dermatitis. Okay, I think most of you know canine atopic dermatitis is one of the very, very common problem. At least 1 in 10 dogs which is presented in the clinical scenario has this problem. And it is a challenging problem for veterinarians to diagnose this case, because this is a case which has to be diagnosed by excluding out all the other possible allergic cases. Okay, that is where canine atopic dermatitis becoming a challenge for the veterinarians. What are some of the facts about the disease? Okay, it is very, very frequent disease, especially for the general practitioners as well as for the dermatology specialists. And there are some predisposition. You know, some of the breeds like Labradors and Boxers, they are predisposed to this disease. And this disease is going to affect the skin barrier. It is going to affect the immune system. And it is going to cause severe itching and pruritus. And the pet owner cannot just watch their pet scratching and itching continuously. And it is going to be a repetition. Again and again it is going to happen. Because unless otherwise it is diagnosed properly, it is not going to get resolved. It is not going to be managed properly. Pet parent will come to us one day, we'll give some medication. If it is not properly managed, he'll go to the other person. And it will go on loop for a very, very long period of time. With allergens, it could be a seasonal one as well. And definitely there are flare-up situations which actually aggravate the problem of the atopic dermatitis. And diagnostic workup, as I mentioned, it is definitely a challenging and complex process. Okay. Currently, how this case is managed, canine atopic dermatitis, it is managed by multimodal treatment approach. It's not that you give a medication, it will get resolved. It's not that you provide a food, it is going to get resolved. It is a multimodal approach which is required. and it is a long-term management. It will not, get cured in a single day. Long-term management, multi-modal, and definitely there is a significant difference in diagnosing and managing the case between the general practitioners and the specialist in this particular dermatology field. And start early. That's very, very important. Whatever medication, whatever the multimodal managemental option that we are going for, we have to start early to avoid aggravations and other complications. And of course, communication is key. We have to educate the clients. We have to talk to them about the client. We have to make them understand that it is not going to go away in a single day. It is going to be there for the pet. Only we can manage and we can provide a quality life to the pets. That is what is the communication or the message that we should definitely not forget to share with the pet owners. Yes. How is when I talked about the multimodal management, there are different aspects to it. One is, the first and foremost is to avoid the allergens. That is very, very important. Unless otherwise we avoid the allergens, it is going to keep on flaring up. Whenever there is a flare, this is going to aggravate the problem. So try to avoid the allergens. Try to use vacuum cleaners, especially where we can get rid of dust mites. Okay. We can regularly give bathing. So that's something we can use we can avoid the allergens. And of course, we have to improve the immunity. Okay, we have to improve the immunity of the pet to fight with the external allergens. Control secondary infections. That is also very, very important. And control the inflammation and pruritus. Itching is something cannot be tolerable by the pet owners. So stop itching first. Then try to manage this in further level. And repair the skin barrier. This is very, very important. So this is a multimodal management. So how nutrition is going to help? Nutrition cannot help in avoidance of allergens. But nutrition can help in improving the immunity. Nutrition can help in reducing the inflammation. Nutrition can help in repairing the skin barrier. Okay. This is the multimodal approach, how nutrition can support. Yes. So what are the pain points of veterinarian? Of course, if time would have permitted, I would have asked you the question, but I am presenting it here. These are the problems veterinarians are facing because of atopic dermatitis. It's a chronic one. It's frustrating for the owners as well as the veterinarians. Diagnostic challenges are there. Cost is one of the biggest problem again to manage for the pet owners also. Time consuming. There are so many challenges for the veterinarians. So we heard the veterinarians, their pain points, and we have come up with the solution. It would be great to provide a food which can really support the management of canine atopic dermatitis. So we went in for a rigorous study, which is a double-blinded placebo-controlled study with some of the key opinion leaders in the field of dermatology. And this study, we have found out, we have taken 3 parameters into the study. One is medication score, because medication is very, very costly nowadays to manage canine atopic dermatitis. We tested for medication score. We tested for itch score, pruritus, using the visual analog scale. And we tested for KDC score, canine atopic dermatitis extent and severity index, okay, which is something has to be a part of diagnostic procedure itself. We tested 3 imported parameters of the disease, and we found out the results, top line results of the product. The medication score was significantly improved. The amount or the cost which has to be spent on medication has come down. Pruritus significantly come down. Disease severity significantly come down. Okay, these are the top line results of this particular product. Okay, in conclusion, as you know, one of the renowned Pascal Prelord. So in conclusion, 82% of the dogs, the medication score significantly reduced. And in 72% of the dogs, the itching is controlled significantly. Okay, this is clinically proven product. So introducing to you all our new range for the outstanding management of canine atopic dermatitis, Skin Topic. So Skin Topic is the product which is available in 2 different SKU. One is Skin Topic regular for all the dogs, and Skin Topic small for small dogs. Okay, there are 2 variants available. We have vet range also, which is not available currently in India, but we have Skin Topic regular and Skin Topic small dogs. Okay, So there are some of the claims. It supports the skin, supports the immune system, supports the, this thing. And of course, what is there in skin topic? We have a unique complex called as dermoxylium, which contains all your skin barrier supporting vitamins and minerals. Licorice, in Tamil we call it as Adimaduram. Okay, licorice and curcumin, turmeric extract. Okay, to improve the immune system and to improve the skin barrier support. Okay, this is all about skin topic. So I recommend confusion in which condition, which product I have to choose, which product I have to recommend. Okay, this is called as decision tree. So if you suspect an allergic case, if you suspect a case of allergy, rule out all the other allergies, like for example, chemical allergy, rule out those allergies. And then if you suspect allergy, straight away go for analergenic. Analergenic is the diet which is extensively hydrolyzed. The molecular weight of the diet is less than 1 kilodalton, and it is from the poultry feather protein, and which has a purified starch. So there is no cross-contamination, there is no chance for allergy. So go ahead for analergenic. And if the resolution happened, continue with it. Okay, that's solution. If the resolution is not happening, most probably it will be atopy. Most probably, because you have already excluded all the allergies. You have already excluded all other, environmental and bacterial infections, etc. So go ahead for the skin topic. And if it is food allergy, you have two options. Either you can continue with analergenic, or you can go with hypoallergenic. Okay. So that's the message I wanted to give. And thank you so much for your time and patiently listening. And let's have a great party tonight. Thank you.
Thank you, Dr. Balaguru from Royal Canin. And that's the end of the session. And we are breaking now. And here in this hall, the cocktails will be given. And the restaurant will be open for the dinner. You can have the dinner in our restaurant. And tomorrow morning, we start by 10 o'clock only, because every time we used to have a delay. So that's the reason we are starting in a delayed one. I expect you all to be here by 9:45 a.m. tomorrow morning. Thank you.